Welcome to the deep dive. We're here again to really plunge into some serious source material, pulling out those critical insights you need to stay right at the forefront of clinical practice.
That's the goal.
Today, we're taking a really deep dive into the European Society for Vascular Surgery. That's ESVS 2021 Clinical Practice Guidelines on the Management of Venous Thrombosis.
A very important document.
Yeah, and this isn't just going to be a quick summary. Our mission here is to go through the provided excerpts from this guideline document in a, well, completely unabridged and highly detailed way. These guidelines, they come from leading experts, and they cover absolutely crucial aspects of venous thrombosis management. Things like diagnosis, different treatment strategies, and importantly, how to handle the condition in specific patient populations. Think of us as your guides, helping you navigate the nuances and the clinical pearls presented within these pages.
And I think the significance of these guidelines for your daily clinical practice really can't be overstated. Venous thrombosis, which, as you know, encompasses deep vein thrombosis, pulmonary embolism, and superficial vein thrombosis, it remains a major health burden globally. So having evidence-based recommendations readily available in what is a complex and, frankly, constantly evolving field is just essential for providing optimal patient care. These guidelines really aim to consolidate that latest evidence into clear, actionable advice for you.
Okay, so here's our roadmap for this deep dive. We'll kick off by understanding the foundation of these guidelines, how they were actually developed, the rigorous methodology they used, and specifically how the evidence was weighed to arrive at these recommendations. Then we're going to launch straight into the core content, spending quite a bit of time on lower extremity deep vein thrombosis. We'll explore its diagnosis, really delve into the intricate treatment strategies, including those critical decisions around anticoagulation duration and the role of adjunctive therapies like compression and maybe early thrombus removal. After that, we'll broaden our scope a bit, explore other types of venous thrombosis like upper extremity DVT and superficial vein thrombosis before tackling management in those specific patient populations, patients with cancer, thrombophilia, renal impairment, or during pregnancy. We'll even touch upon the areas that the Guideline Committee identified as needing future research, highlighting where the knowledge gaps, well, still lie.
That's right. And this is going to be a thorough exploration. For you, as a specialist clinician, we'll be breaking down not just what the recommendations are, but also the level of evidence and the class of recommendations supporting each one. And we'll discuss the clinical nuances that factor into applying these guidelines in the real world, patient by patient. We'll take it step by step, making sure we cover all the essential details presented in the source material.
Okay, great. Let's unpack this then. But before we dive into the real substance, there's a dedication mentioned in the source that I think we should acknowledge first.
Yes, absolutely.
The guidelines are specifically dedicated to the memory of Dr. Clive Kieran of McMaster University in Hamilton, Ontario, Canada. The source really highlights his significant contributions to the field of thrombosis and antithrombotic treatment. His involvement in the review process for these very guidelines was noted, specifically mentioning his extensive reviews of the first and second versions of the manuscript. The dedication points out his punctuality and notably describes his review of the first round as being, get this, 16 pages long, containing just numerous detailed and helpful comments.
Wow, that's thorough.
Isn't it? Sadly, he passed away on June 3rd, 2020, just one day after being invited to review the final version. The Guideline Committee states they will always remember Dr. Kieran for his numerous contributions, including his input on this important document. It's quite a poignant detail, I think, reminding us of the collaborative effort and the individuals who really shaped these critical resources.
It certainly does. A fitting tribute. Moving now to the general aspects, Section 1 of the guidelines. The overall purpose here is, well, quite clear. To provide clinicians like you with clear, evidence-based recommendations for managing patients diagnosed with venous thrombosis. The focus is intentionally placed on conditions and situations that are likely to be commonly encountered by the clinical teams who will be the primary end users of this document, you see. The scope is broad, covering acute deep vein thrombosis of the lower extremity, which is the primary focus unless otherwise stated, but also upper extremity deep vein thrombosis, superficial vein thrombosis, and even thrombosis occurring in unusual sites. Importantly, the guidelines go beyond just treatment modalities. They also incorporate aspects like investigations, and they consider health economics, reflecting a really comprehensive approach to managing these patients. They also make a point of considering the patient's perspective, which is a notable inclusion in recent European Society for Vascular Surgery guidelines.
And it's definitely worth detailing the methodology behind how these guidelines were created, as it really underscores their credibility. The process, it was initiated back in 2017 by the European Society for Vascular Surgery Guidelines Committee. A dedicated guideline writing committee consisting of 16 members was responsible for actually writing and approving the document. This committee, well, it was primarily composed of European Society for Vascular Surgery members, but also included eminent thrombosis experts from other relevant societies. These experts were apparently selected based on their clinical experience, strong publication records, and, expertise in the field. The process involved a rigorous review, including a formal external expert peer review process. Additionally, the document was reviewed and approved by the European Society for Vascular Surgery Guidelines Committee itself and by the editors of the European Journal of Vascular and Endovascular Surgery, ensuring multiple layers of scrutiny before publication. It sounds pretty robust.
Well, absolutely. And the strategy for creating these guidelines involved a systematic approach to literature search and selection. Literature searches were performed up to August 2019. The Guidelines Committee does acknowledge that relevant articles published after this date, or perhaps in other languages, were considered for inclusion, but only if they were deemed to be of, let's say, paramount importance to the guideline recommendations. This reflects a commitment to incorporating truly groundbreaking new evidence, even late in the process.
Okay, let's talk about how the evidence was weighed, because this is fundamental to understanding the strength behind each recommendation you'll find. The members of the Guideline Writing Committee reviewed and summarized the relevant peer-reviewed published literature. Conclusions and the subsequent recommendations were drawn based on this available scientific evidence. The guidelines explicitly state that they use the European Society of Cardiology grading system for presenting their clinical practice recommendations, which is, a widely recognized and respected system. For each recommendation, there's a letter grade indicating the level of current evidence supporting it.
Yes, and it's important for you to break down what these levels of evidence actually mean. Table 1 of the source material outlines this quite clearly. Level of evidence A indicates that the data is derived from multiple randomized clinical trials or meta-analyses. So verbally describing this, it means there's strong evidence coming from high-quality studies that have pooled data or are large-scale, well-designed trials. Very solid. Level evidence B means the data is derived from a single randomized clinical trial or large non-randomized studies. This level indicates evidence that's, less robust than level A because it relies on maybe just one large trial or studies that don't involve randomization, but it's still considered significant evidence. Level of evidence C is based on a consensus of experts' opinion in small studies, retrospective studies, and registries. This is the level of evidence that often guides clinical practice when those higher levels of evidence from randomized trials or large studies just aren't available. It represents what experienced clinicians and researchers agree upon based on the available, albeit less robust, data.
Right, and building on those levels of evidence, the guidelines then assign a class of recommendation, which indicates the strength of that recommendation based on the evidence and the expert opinion. Table 2 in the source describes these classes. Class 1 indicates that there is evidence and order general agreement that a given treatment or procedure is beneficial, useful, and effective. Pronounce Class 1. This is the strongest recommendation you can get, meaning it is strongly recommended in clinical practice. Basically, do this. Class 2 represents situations where there is conflicting evidence and maybe a divergence of opinion about the usefulness or efficacy of the given treatment or procedure. So this is where things are a bit less clear-cut, right? The recommendation isn't as definitive.
Exactly. It's split into two subclasses.
Right. Class 2A is a subdivision where the weight of evidence or opinion is in favor of the usefulness or efficacy. Verbally described, this means the treatment or procedure is generally recommended, but there isn't that overwhelming consensus or evidence you see with Class 1. And then there's Class 2B, the other subdivision, where the usefulness or efficacy is less well established by evidence or opinion. So described verbally, this means the treatment or procedure may be considered. It suggests it's a weaker recommendation than Class 2A, reflecting more uncertainty. Finally, Class 3 means there is evidence and guarded general agreement that a given treatment or procedure is not useful or effective, and in some cases, it might even be harmful. Pronounced Class 3, this is a strong negative recommendation, advising against the treatment or procedure. Essentially, don't do this.
And it's crucial to remember when you're interpreting these recommendations, the guidelines emphasize that the lower the class number, so Class 1 being the lowest and strongest, followed by Class 2A, 2B, and then Class 3, the greater the evidence and or general agreement is in favor of an intervention. This grading system is absolutely fundamental to understanding the weight given to each piece of clinical advice provided in the document.
Now, one effort they made to improve accessibility and interpretability, particularly for patients and the public, involved producing a plain English summary of the guideline document. This summary was then subjected to a lay review process. Draft information for patients was created for each subchapter and then read and amended by both a vascular nurse specialist and a layperson. And then further evaluation of these lay summaries was conducted by 8 patients who actually had a history of venous thrombosis within the UK National Health Service, as well as 4 lay members of the public who didn't have a history of venous thrombosis. Apparently, the background and rationale for the guidelines were explained to all participants, and they were encouraged to give honest feedback on any aspect of the summary.
That's good practice.
Yeah, and several themes emerged from this feedback. Firstly, both patients and lay members recognized the importance of venous thrombosis as a condition and specifically welcomed being engaged in this process. Some apparently commented that other medical conditions seem to get much more public attention than VTE. All the respondents acknowledged the importance of anticoagulant medication, particularly appreciating that significant advances had been made with the widespread use of direct oral anticoagulants.
That's understandable.
Most of the feedback, though, it centered around interventions intended to reduce the long-term consequences of venous thrombosis, especially compression therapy and early thrombus removal strategies for both upper and lower extremity deep vein thrombosis. Notably, all respondents provided positive feedback regarding compression therapy, with the majority of patients who had experienced venous thrombosis stating that it actually hadn't been offered to them at the time of their initial presentation.
Interesting.
That is interesting. Yeah. They appreciated that their recommendations were based on the latest published evidence, but they expressed a strong desire that even if the benefit of an intervention was uncertain or maybe only modest, it should still be discussed with future patients. The Guideline Committee explicitly acknowledges this feedback, urging clinical teams managing patients with venous thrombosis to ensure that potential interventions are discussed with patients and that the rationale for offering, or maybe not offering, interventions like early thrombus removal is clearly explained to the patient. This feedback from the focus group was actually used to amend and improve the clarity of the lay summaries included in the guidelines.
Excellent. So just to recap the general aspects of these guidelines before we move on, we've discussed their clear purpose, providing you with evidence-based recommendations for commonly encountered venous thrombosis conditions. We covered their rigorous methodology, involving writing and review committees, external peer review, and editorial approval. We talked about the strategy for literature selection and, crucially, detailed the European Society of Cardiology grading system used for weighing the evidence. This includes the levels of evidence A, B, and C, which tell us about the quality of the studies the recommendations are based on. And we've elaborated on the classes of recommendations Class 1, 2A, 2B, and 3, which convey the strength of the recommendation for or against an intervention, emphasizing that a lower class number signifies stronger support. Finally, we highlighted the important effort to include the patient perspective through lay reviews and the valuable feedback received, which really underscores the need for open communication with patients about potential interventions.
Right, okay. Let's move into the real heart of the matter for many clinicians. Lower extremity venous thrombosis. Starting with section 2.1, it's introduction, epidemiology, and the burden of the disease.
Okay. Looking at the epidemiology, the annual incidence of a first symptomatic episode of deep vein thrombosis in the adult population, it ranges from about 50 to 100 cases per 100,000 people. Now, when you add in pulmonary embolism events, the overall incidence of venous thromboembolism, or VTE, is around 25% higher than that DVT-only figure. This data is typically derived from 2 main types of published epidemiology studies, either retrospective analyses using national or regional patient cohorts studied over several years, or prospective studies primarily based on ultrasound performed over shorter periods, typically 1 to 2 years.
And the incidence of deep vein thrombosis, it shows some interesting variations. It's slightly greater in women aged, say, 20 to 45 years, but then men tend to have a higher incidence between 45 and 60 years of age. The guidelines note that the incidence is actually higher for males across all age groups if you exclude those female-specific risk factors like oral contraceptives and pregnancy. A really striking finding is the 2-fold increase in incidence for every 10-year increase in age. It really climbs steeply. The numbers become quite significant over a lifetime. At least 1 in 12 middle-aged adults will develop either deep vein thrombosis or pulmonary embolism in their remaining lifetime. And consistent with that age trend, 60% of all venous thromboembolism events occur in patients aged over 65 years old.
Significant.
Yeah. There are also racial variations noted. African Americans have a higher incidence of deep vein thrombosis compared to Caucasians and Native Americans, whereas Asian populations, specifically cited as China and Korea, seem to have a lower incidence. A seasonal variation is also observed. with a higher incidence of venous thromboembolism in the winter months, peaking specifically in February. And for patients with unprovoked deep vein thrombosis, meaning there's no readily identifiable triggering factor, the risk of recurrent venous thromboembolism is substantial, around 10% in the first year and increasing to 30% after 5 to 8 years. This really highlights the long-term challenge with these unprovoked events.
Absolutely. Moving to risk factors now, section 2.1.2. We commonly categorize deep vein thrombosis as either provoked or unprovoked, as you said. Provoked deep vein thrombosis is associated with identifiable risk factors. The common ones listed in the source include active cancer, particularly if the patient is either receiving treatment within the previous 6 months or currently receiving palliative treatment. Other factors are acute medical illness, surgery, trauma, immobility, especially if it's hospital-acquired and lasts for at least 3 days. Obesity is also listed, as are inflammatory diseases and infection, hormone therapy containing estrogen, pregnancy, particularly the postpartum period, long-distance travel, recent hospitalization, and antiphospholipid syndrome. It's noted that primary varicose veins are considered only a minor risk factor in this context.
And the source mentions a more, recently recognized factor: prolonged computer-related seated immobility syndrome as a potential risk factor, something perhaps more relevant today.
Possibly, yes.
Shifting to inherited risk factors, the most common one mentioned is a non-O blood type, which is associated with roughly double the risk of venous thromboembolism. Another common thrombophilia is heterozygous factor V Leiden gene polymorphism. This particular genetic alteration can increase the risk of venous thromboembolism by a factor ranging from 3 to 8 in selected populations. Severe thrombophilia, which includes conditions like homozygous factor V Leiden, deficiencies of antithrombin, protein C or protein S, and antiphospholipid syndrome, significantly increases the risk of deep vein thrombosis by a factor of, 20 to 80-fold. Huge increase.
Massive, yes.
It's also noted that the important risk factors for arterial thromboembolism are distinct and different from those for venous thromboembolism. Worth remembering.
Definitely. Okay, thinking about these risk factors then, let's pose a sort of board-style question for you, our listener. If you see a 55-year-old man presenting with deep vein thrombosis, and you've done a thorough history and examination, and the only apparent risk factor you identify is obesity, according to these guidelines, how would you categorize his deep vein thrombosis, provoked or unprovoked? And what's the clinical significance of that categorization? Well, based on the list provided, obesity is explicitly listed as a common risk factor for deep vein thrombosis. So even if it's the only apparent factor in this 55-year-old man, his deep vein thrombosis would be categorized as provoked, right? Because there is an identifiable persistent risk factor present.
Exactly, and the clinical significance is key here, as you highlighted. Obesity isn't transient like surgery or trauma. It's a condition that requires ongoing management and is associated with an elevated risk that doesn't simply disappear unless the obesity is resolved. This distinction between provoked by a transient factor and provoked by a persistent factor like obesity is crucial later when you're considering the duration of anticoagulation therapy, as patients with persistent risk factors generally have a higher ongoing risk of recurrence if anticoagulation is stopped compared to those with transient risk factors.
Very well put. Okay, let's delve into the pathophysiology of deep vein thrombosis, section 2.1.3. Deep vein thrombosis involves the formation of a blood clot, typically starting, as we said, in the calf veins. These clots have the potential to extend proximally, sometimes reaching the popliteal, femoral, or even the iliac veins. Now, while most calf clots often undergo spontaneous lysis, meaning the body breaks them down naturally, proximal clots, particularly in the iliac segments, only resolve fully in about 20% of cases. This persistent thrombus or residual obstruction is really key. Prolonged venous obstruction can lead to chronic venous outflow obstruction, hindering blood return. And even after the vein partially recanalizes, meaning the clot resolves enough for some flow to resume, the inflammatory reaction to the original thrombus can cause secondary venous valve damage. This damage results in valvular reflux, where blood flows backward, increasing pressure in the veins below.
And this combination of venous obstruction and/or reflux, that's the mechanism that commonly leads to the development of post-thrombotic syndrome, or PTS. The initial signs and symptoms of post-thrombotic syndrome typically appear within about 3 months following the acute deep vein thrombosis event. Unfortunately, these symptoms and signs can progress and deteriorate over years, really highlighting the chronic nature of this complication. The most extreme and severe clinical presentation of deep vein thrombosis can occur when there is occlusion of the common femoral vein and the external iliac vein. This completely obstructs the outflow of blood from all the deep and superficial veins of the limb, as well as collateral veins, leading to a severe and painful condition termed phlegmasia cerulea dolens.
A dramatic presentation.
Yes. Now, anticoagulation therapy plays a vital role in managing acute deep vein thrombosis by reducing the risk of a pulmonary embolism and preventing the thrombus from extending or progressing further. However, it's important for you to understand that the actual resolution of the thrombus, the breaking down and clearing of the clot itself, is dependent on the body's own endogenous fibrinolytic activity within the affected veins. Anticoagulation doesn't typically lease the clot. It prevents new clot formation and extension.
Understanding the clinical manifestations of deep vein thrombosis, section 2.1.4, is critical for timely diagnosis. The symptoms and signs are generally more severe as the deep vein thrombosis extends proximally, meaning higher up the leg. Pain, tenderness, and swelling are the typical presenting features. When the deep vein thrombosis is located at the iliofemoral level, involving the iliac and femoral veins, the leg is usually considerably swollen and quite painful. Patients experience decreased mobility and significant edema, starting from the groin and extending distally. This is due to the limited venous collateral drainage in the pelvic region when the main outflow tract is blocked. Prominent superficial veins, often non-varicose collaterals, may be visible as the body tries to reroute blood flow. And interestingly, for deep vein thrombosis originating higher up in the iliac veins, back pain may actually be an early feature, which can sometimes be a bit misleading in the initial assessment.
Right, and it's also crucial for clinicians like you to be aware of several lower extremity disorders that can mimic the signs and symptoms of deep vein thrombosis, as differentiating these is key to appropriate management. These conditions include things like lymphedema, superficial vein thrombosis itself, established post-thrombotic syndrome from a previous event, cellulitis, a ruptured Baker cyst, especially presenting in the calf, and trauma. These can all present with pain, swelling, and redness, necessitating careful evaluation. It's noted that isolated calf deep vein thrombosis, involving only the deep veins below the knee, may present with less pronounced symptoms that are often confined just to the calf area, making the clinical picture perhaps less dramatic than with proximal disease.
Okay, let's take a moment for a micro recap of what we've covered in the introduction to lower extremity venous thrombosis. We detailed the incidence and burden of the disease, discussing the rates, age, sex, racial, and seasonal variations, and the significant risk of recurrence, especially for unprovoked events. We then explored the key risk factors, distinguishing between provoked and unprovoked events, listing common factors, and delving into more specific ones like prolonged seated immobility syndrome and inherited thrombophilias, including our discussion of obesity as a persistent risk factor and its clinical significance. We outlined the pathophysiology, explaining how acute clot can progress to chronic issues like post-thrombotic syndrome and the severe presentation of phlegmasia cerulea dolens, and clarified the role of anticoagulation versus the body's own fibrinolysis. Finally, we cover the variable clinical presentation based on clot location and the importance of differentiating deep vein thrombosis from conditions that can mimic its symptoms.
Okay, great summary. Now we move into the really critical process of diagnosis, section 2.2.
All right, so section 2.2.1 focuses on the initial assessment. The guidelines recommend using clinical assessment, often incorporating a pretest probability score as the very first step in evaluating a patient with suspected deep vein thrombosis.
And the widely used pretest probability score mentioned is, of course, the Wells Deep Vein Thrombosis score. Table 3 in the source describes the components of this scoring system. It lists key clinical features, each assigned 1 point. Active cancer, defined as receiving treatment within the previous 6 months or currently receiving palliative treatment. Paralysis, paresis, or recent cast immobilization of the lower extremities, being recently bedridden for at least 3 days, or having undergone major surgery within the previous 12 weeks requiring general or regional anesthesia.
Keep going.
Localized tenderness along the distribution of the deep venous system. Entire leg swelling, calf swelling that measures at least 3 centimeters larger than the asymptomatic side, measured 10 centimeters below the tibial tuberosity. Pitting edema confined to the symptomatic leg, unilateral collateral superficial veins that are non-varicose, and previously documented deep vein thrombosis. And then importantly, for an alternative diagnosis that is considered at least as likely as deep vein thrombosis, 2 points are subtracted. The points are then summed up to get a total score.
Exactly. And the source notes that the Wells score can be used to categorize the pretest probability in 2 main ways. Either dichotomized, where deep vein thrombosis is considered likely if the score is greater than or equal to 2, or unlikely if the score is less than 2, or using a 3-category approach, where a score of greater than or equal to 3 indicates a high likelihood, a score of 1 to 2 indicates moderate likelihood, and a score of less than or equal to 0 indicates a low likelihood. The guidelines state that the dichotomized Wells score is simpler and more widely used, and significant advantages to stratifying into 3 groups haven't really been demonstrated in studies.
But it's crucial to understand the limitations of the Wells score, isn't it? Even in the low-risk group defined by the Wells score, the probability of deep vein thrombosis has been reported to be as high as 5%. So this means the score cannot be used as a standalone test to definitively confirm or exclude deep vein thrombosis. However, its value is, well, undeniable when used in conjunction with further investigations, specifically D-dimer measurements and Hundor ultrasound. It becomes a valuable tool for accurate decision-making within a diagnostic pathway.
Precisely. Section 2.2.1.2 discusses a D-dimer measurement. D-dimers are specific fibrin degradation products. Their levels are increased in any condition where there is increased fibrin formation, which is certainly the case in venous thrombosis. The most commonly used quantitative D-dimer assays have a sensitivity of approximately 95%. Critically, they possess a very high negative predictive value, ranging from 99% to 100%. This high negative predictive value is what makes D-dimer testing so valuable for safely ruling out deep vein thrombosis, particularly when combined with a low clinical suspicion based on the Wells score.
However, false negatives can still occur with D-dimer testing. This is apparently more likely in patients who are already receiving anticoagulants, in cases of isolated calf deep vein thrombosis where the clot burden might be smaller, or when symptoms have been present for a longer duration, typically more than 2 to 3 weeks, allowing for more clot organization.
And the major limitation of D-dimer testing is its low specificity, which ranges from only about 35% to 55%. False positives are common because numerous other conditions can cause elevated D-dimer levels. These include things like infection, cancer, pregnancy, and older age, where baseline D-dimer concentrations are naturally higher. Although age-adjusted cutoffs have been introduced in an attempt to improve specificity, it remains low, reported as 51.1% in one study cited. So still a lot of false positives.
Right. So moving to imaging, section 2.2.1.3 covers ultrasound, which is presented as the first-line imaging modality for investigating deep vein thrombosis in symptomatic patients. The guidelines describe 2 distinct ultrasound assessment approaches commonly practiced: 2 or 3-point compression ultrasound scanning, known as CUS, and whole leg ultrasound scanning, or WLUS. In CUS, the patency of the deep veins is assessed only in specific key territories, usually the common femoral vein, the popliteal vein, and sometimes the femoral vein. Whole leg ultrasound scanning, well, as the name implies, examines the entire deep venous system of the leg.
Yeah, and the sensitivity and specificity of these ultrasound methods are generally high for detecting proximal deep vein thrombosis. However, the sensitivity for isolated calf deep vein thrombosis is lower, particularly with that 2 or 3-point CUS approach, as it may miss clots confined to the calf veins. The rationale for using CUS in certain diagnostic algorithms, for example, in patients with low clinical suspicion combined with a negative D-dimer, is to safely rule out proximal deep vein thrombosis on the day of referral, potentially reducing the risk of overdiagnosis of lower-risk isolated calf deep vein thrombosis. However, the source notes that such an algorithm using CUS isn't formally validated, and therefore the guideline writing committee actually favors whole-leg ultrasound scanning whenever there is a clinical suspicion of calf deep vein thrombosis, and whole-leg ultrasound scanning is available, precisely because CUS has that potential to miss those isolated calf clots.
Okay, that makes sense. What about other imaging modalities? Section 2.2.1.4 discusses computed tomography venography, or CTV. CTV is described as an effective technique for diagnosing proximal deep vein thrombosis, particularly useful perhaps in patients where there is also a suspicion of pulmonary embolism concurrently. Its sensitivity and specificity for detecting proximal clots are considered comparable to ultrasound.
True, but CTV has limitations, notably radiation exposure, which is a significant concern, especially when compared to ultrasound. It also requires the administration of intravenous contrast material, and there can be issues with adequate venous opacification, particularly in the presence of significant proximal obstruction, which can make interpretation challenging sometimes.
Okay. Section 2.2.1.5 introduces magnetic resonance venography, or MRV. MRV is another alternative imaging technique that can be particularly useful in situations where intravenous contrast agents are contraindicated for the patient, or when evaluating deep vein thrombosis in specific anatomical locations where ultrasound may be difficult.
Yes, the guidelines discuss its role and mention its advantages, primarily the absence of radiation exposure. However, Disadvantages include its higher cost, potentially limited availability in some centers, and the need for specific magnetic resonance imaging sequences tailored for venous imaging.
Right. And finally, section 2.2.1.6 mentions venography.
Ah, yes. Venography is described as the historical gold standard for diagnosing deep vein thrombosis. However, it is an invasive procedure, requires the injection of intravenous contrast, and involves exposure to radiation.
So for these reasons, venography is now seldom performed in current clinical practice. It's generally reserved for specific situations, such as when other imaging investigations have yielded inconclusive results, or maybe when a concurrent catheter-based interventional procedure is being planned, as venography can be performed as part of that process.
Exactly. So given the variety of diagnostic methods available, the guidelines really emphasize the critical need for using a validated diagnostic pathway. This pathway typically combines clinical assessment, often using a pretest probability score like the Wells score, with D-dimer measurement and appropriate imaging, primarily ultrasound. Following such a structured pathway is imperative to ensure accurate decision-making, minimizing the risk of both false negative results, where deep vein thrombosis is missed, and importantly, overdiagnosis. Figure 1 in the source, which is a flowchart for diagnosis and investigations for deep vein thrombosis, visually represents this structured approach quite well.
Okay, let's pause for a quick micro recap on the diagnostic workup for lower extremity deep vein thrombosis. We covered the initial assessment, starting with clinical evaluation and the utility of the Wells score, understanding both its value in stratifying risk and its limitations as a standalone test. We then detailed the role of D-dimer measurement, emphasizing its high negative predictive value for ruling out deep vein thrombosis in low-risk scenarios, while also highlighting its limitations due to low specificity and potential for false positives. We delved into ultrasound as the first-line imaging, explaining the difference between 2-3-point compression ultrasound scanning, CUS, and whole-leg ultrasound scanning, WLUS, and their respective roles and limitations. We briefly mentioned the other imaging options discussed, including computed tomography venography, CTV, magnetic resonance venography, MRV, and the historical role of venography, which is now rarely used. Finally, we reinforced the importance of following a structured, validated diagnostic pathway, combining these tools for accurate diagnosis.
Excellent summary. Moving on to section 2.2.3, investigating for pulmonary embolism. The guidelines highlight that occult, meaning clinically silent, pulmonary embolism is known to be prevalent in patients presenting with lower extremity deep vein thrombosis. Several studies have reported that around 30% to 40% of patients diagnosed with deep vein thrombosis have findings on high-probability pulmonary scintigraphy or computed tomography suggesting clinically silent pulmonary embolism. Some studies have even reported prevalences as high as 66%.
Wow, that high. And the prevalence of clinically silent pulmonary embolism in patients diagnosed with deep vein thrombosis is noted to increase with age. It's also higher in patients with proximal deep vein thrombosis compared to those with isolated calf deep vein thrombosis. A systematic review specifically looking at patients with calf deep vein thrombosis reported a prevalence of silent pulmonary embolism of about 13%.
The clinical relevance of silent and undetected pulmonary embolism in patients with deep vein thrombosis is significant. If these patients develop subsequent pulmonary symptoms, they may be mistakenly diagnosed as having recurrent pulmonary embolism despite being on anticoagulation. This misdiagnosis can potentially lead to unnecessary therapeutic measures, such as the insertion of an inferior vena cava filter. Furthermore, silent pulmonary embolism can involve even the central pulmonary arteries, potentially leading to the long-term complication of pulmonary hypertension. And patients with deep vein thrombosis who are found to have silent pulmonary embolism are also at a higher risk of suffering subsequent symptomatic recurrent pulmonary embolism. So it's not entirely benign.
No, definitely not. Okay, section 2.2.4 addresses the investigation for occult cancer in patients with unprovoked venous thromboembolism. The question here is whether extensive screening for malignancy is warranted in all patients presenting with venous thromboembolism that isn't provoked by a clear, strong, transient, or persistent risk factor. The guidelines summarize findings from meta-analyses that have amalgamated published data comparing more extensive investigation strategies with limited screening only in patients with unprovoked venous thromboembolism. These meta-analyses found that extensive screening strategies did diagnose a higher number of malignancies compared to limited screening, about 7.5% versus 6.1%, with a relative risk of 1.22. However, and this is really the key implication, these extensive screening strategies conferred no significant reduction in all-cause mortality, relative risk about 0.86 in one meta-analysis, or cancer-related mortality, relative risk ranging from 0.86 to 0.93 in different studies.
So the bottom line is, while finding more cancers, the evidence does not currently support a benefit in terms of reducing death from either cancer or any cause. Thus, routine extensive screening for occult cancer in patients with unprovoked venous thromboembolism is often not recommended based on this lack of demonstrated mortality benefit, though the guidelines present the data rather than a specific class recommendation in this section.
Right. Now, Section 2.2.5 focuses on the investigation for thrombophilia. When should we be thinking about this?
The guidelines discuss specific clinical scenarios where thrombophilia testing should be considered in patients who have experienced deep vein thrombosis. First, testing for antiphospholipid antibodies should be considered for patients with unprovoked deep vein thrombosis, particularly if a decision is being contemplated about stopping anticoagulation therapy in the future. This is actually listed as Recommendation 12, which we'll circle back to later.
Okay.
Secondly, consideration of thrombophilia testing is also deemed important in patients who present with deep vein thrombosis at an unusual site, say a cerebral vein. This is particularly relevant for those whose event was unprovoked and who also have a strong family history of venous thromboembolism in a first-degree relative, especially if the patient is under 45 years of age.
And thirdly,
for female patients with deep vein thrombosis, antiphospholipid antibody testing may be especially useful if they have a history of recurrent pregnancy loss, as antiphospholipid syndrome can be associated with both venous thrombosis and adverse pregnancy outcomes.
okay. And the guidelines provide details on the different types of recognized thrombophilia, right? Presented in Table 5.
Yes, they're broadly categorized as hereditary or acquired. Hereditary examples listed include deficiencies of antithrombin, protein C, and protein S, factor V Leiden, activated protein C resistance, prothrombin, G2210A variants, dysarthrombinemia, factor 13-34-DAVL, fibrinogen, G1383-4T, A and/or B alleles of the ABO blood group, and prothrombin Yukahashi. Acquired thrombophilia examples include antiphospholipid antibodies, paroxysmal nocturnal hemoglobinuria, and myeloproliferative syndromes with the JAK2 V617F mutation. Table 20, which is actually located later in Chapter 4.4.1, provides the prevalence and relative risk for the development of venous thromboembolism for the most common hereditary and acquired hematological alterations related to clinical thrombophilia.
Can we delve a bit deeper into the mechanisms and clinical implications of some of the specific hereditary deficiencies?
Sure. Let's start with antithrombin. Antithrombin is the main natural inhibitor of thrombin. Its inhibitory activity is dramatically enhanced by binding to heparin or heparin sulfate. The source mentions that with the exception of specific mutations affecting the heparin binding site, homozygous antithrombin deficiency is considered incompatible with life. However, heterozygous antithrombin deficiency, where individuals have one normal and one affected gene, results in a significant increase in venous thromboembolism risk, estimated at 5 to 20-fold. Affected individuals with heterozygous deficiency typically present with thrombosis at an early age.
Okay, what about protein C?
Protein C is a vitamin K-dependent protease synthesized in the liver. When activated by thrombin, it exerts an anticoagulant effect by proteolytically degrading activated coagulation factors V and 8. Homozygotes, or compound heterozygotes for severe protein C deficiency, are described as just compatible with life, presenting with spontaneous skin necrosis in neonatal life, a severe condition known as neonatal purpura fulminans. If less severely affected with lower but not absent protein C levels, they still have a substantial 7 to 10-fold increased risk of venous thromboembolism later in life. The guidelines note that patients with purpura fulminans require protein C replacement, typically with fresh frozen plasma or protein C concentrates. Individuals with protein C deficiency are also at an increased risk of skin necrosis during the initiation of vitamin K antagonist therapy like warfarin. This is because the half-life of protein C is shorter than that of the other vitamin K-dependent coagulation factors, leading to a temporary prothrombotic state when initiating warfarin before the full anticoagulant effect on factors 2, 7 on X, and X is achieved. This is known as warfarin-induced skin necrosis.
Right, I remember that. And protein S.
Protein S is also a vitamin K-dependent protease that functions as a cofactor for the anticoagulant function of activated protein C. Protein S circulates in the blood in two forms. Approximately 40% is free protein S, and the rest bound to complement C4b binding protein. Only the free form of protein S possesses anticoagulant activity. Deficiency of protein S is associated with an increased risk of venous thromboembolism ranging from 2 to 11-fold, similar to the risk seen with protein C deficiency.
Okay. And regarding acquired thrombophilia, the guidelines focus on antiphospholipid antibodies.
Yes. The source explained that for diagnosing antiphospholipid syndrome, or APS, 3 key assays are typically performed. The lupus anticoagulant assay, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. It correctly points out that the term lupus anticoagulant is a double misnomer. It is neither a test specifically for lupus, nor is it an in vivo anticoagulant. Rather, it's an in vitro phenomenon where the antiphospholipid antibody interferes with clotting tests, causing a prolonged clotting time. The catastrophic antiphospholipid syndrome is an aggressive and severe variant characterized by multi-organ system involvement, specifically including small vessel thrombosis. It can develop rapidly, and it's a life-threatening medical condition with a high reported mortality rate of 50%. Antiphospholipid syndrome is also associated with disseminated intravascular coagulation, or DIC, in about 25% of cases.
Wow. Okay, are there practical considerations when performing thrombophilia testing that clinicians need to be aware of?
Definitely. The timing of testing relative to anticoagulation therapy is really important because most plasma-based tests, which measure the function or level of these clotting factors, are affected by vitamin K antagonists and direct oral anticoagulants, the DOACs. The source notes that to perform most plasma thrombophilia tests reliably, DOACs need to be stopped for at least 3 days beforehand. However, some tests, like antithrombin activity, can potentially be performed while a patient is taking DOACs or VKAs. Genetic testing, like for factor V Leiden or prothrombin G202010A, can be performed at any time as it's not affected by anticoagulation.
Right.
The guidelines recommend that any abnormal phenotypic plasma thrombophilia tests should always be repeated on a second set of blood samples collected on a different day for confirmation, just to rule out transient abnormalities. Patients who were tested while receiving anticoagulants, particularly VKAs or DOACs, should ideally be retested at a later date when they are off anticoagulation, as the levels of protein C and S and the results of routine lupus anticoagulant testing are definitely affected by these medications.
That's a really important practical point.
It is. And it's also emphasized that interpreting thrombophilia test results requires context, considering other coexisting risk factors. Consultation with a specialist is important for appropriate patient counseling and long-term follow-up, particularly given the rapid advances in managing these conditions. For example, patients with antithrombin deficiency might require plasma or recombinant antithrombin concentrates during times of hemostatic stress when they cannot receive standard anticoagulation, like around surgical procedures. Specialist input is key there.
Absolutely. Now, let's look at the specific recommendations regarding thrombophilia testing mentioned in this section again. Recommendation 9 states, for patients with provoked deep vein thrombosis, thrombophilia testing is not recommended. This is a strong negative recommendation, Class 3, based on Level C evidence, which is consensus opinion. The rationale here is that the presence of a clear provoking factor makes it less likely that identifying an underlying thrombophilia will significantly change the immediate management strategy or duration of anticoagulation. Makes sense.
It does.
Then, Recommendation 12 states, for patients with unprovoked deep vein thrombosis, testing for antiphospholipid antibodies should be considered if a decision to stop anticoagulation is contemplated. This is a Class 2A recommendation based on Level C evidence. The rationale for this is that identifying antiphospholipid syndrome has significant implications for long-term management, often warranting indefinite anticoagulation, and this diagnosis is particularly important to consider before deciding to discontinue therapy in an unprovoked deep vein thrombosis patient.
Exactly right. So bringing together our discussion on deep vein thrombosis diagnosis and investigations in a mega recap. We've covered the diagnostic approach, starting with clinical assessment and the Wells score, understanding its utility and limitations. We detailed the role of D-dimer, emphasizing its sensitivity and high negative predictive value for ruling out DVT in low-risk scenarios, while also acknowledging its specificity issues and common causes of false positives. We discussed ultrasound as the cornerstone of imaging, comparing CUS and WLUS and outlining their respective roles. We briefly touched upon other imaging options like CTV, MRV, and the rarely used venography, and highlighted the importance of following a structured diagnostic pathway. We looked at the findings regarding occult PE, noting its prevalence and clinical relevance, and discussed the evidence on occult cancer screening, explaining why extensive screening isn't routinely recommended based on a lack of demonstrated mortality benefit. Finally, we delved into the detailed approach to thrombophilia testing, covering who should be tested, when the test should be performed relative to anticoagulation, what specific types of tests are relevant, how to interpret results, detailing specific types of thrombophilia and their associated risks, and outlining the guidelines' specific recommendations on testing for provoked versus unprovoked DVT, particularly the nuance regarding antiphospholipid antibodies when considering stopping anticoagulation.
Perfect. Let's take a quick micro recap moment here, focusing specifically on the management principles for thrombophilia and the recommendations we just covered regarding testing. We established that while thrombophilia increases the risk of VTE, and especially recurrence, it's just one piece of the puzzle in overall risk assessment. Anticoagulation is generally effective regardless of the thrombophilia type. The key recommendations we covered are Recommendation 9, strongly advising against routine thrombophilia testing in patients with provoked DVT, and Recommendation 12, suggesting considering antiphospholipid antibody testing in unprovoked DVT patients if you're contemplating stopping anticoagulation, recognizing the significant impact of an APS diagnosis on long-term management. This really highlights how identifying specific high-risk conditions like APS can alter the duration strategy, even if the initial treatment isn't necessarily different.
Very good point. Now we transition to Section 2.3, the treatment of deep vein thrombosis, focusing initially on anticoagulation. Section 2.3.1 outlines the three distinct phases of anticoagulation treatment for deep vein thrombosis. First, there's the initial treatment phase, which typically lasts up to about 10 days. The primary aim during this phase is to rapidly achieve a therapeutic level of anticoagulation to prevent clot extension and early pulmonary embolism. Second is the principal treatment phase, which is generally considered to be the first 3 months of therapy. The focus here is on preventing early recurrence of venous thromboembolism and further pulmonary embolism. Third is the extended treatment phase, which is considered for patients beyond the initial 3 months. This phase is typically considered for patients who are at a higher risk of recurrence to provide long-term protection against future events.
Okay, 3 phases. And Section 2.3.2 introduces the main classes of anticoagulants used in treating deep vein thrombosis. These include unfractionated heparin, UFH, low molecular weight heparins, LMWH, vitamin K antagonists, VKA, fondaparinux, and the direct oral anticoagulants, DOACs.
Exactly. And Section 2.3.3 delves into the anticoagulant properties and dosing for each of these agents, drawing heavily from the practical details provided in the source and its associated tables. To understand how they work, Figure 2 provides a simplified illustration of the coagulation cascade. Unfractionated heparin works by binding to antithrombin, significantly enhancing its activity to inhibit both factor Ds and factor 3, which is also known as thrombin. Low molecular weight heparins and fondaparinux also work indirectly via antithrombin, but they primarily inhibit factor Ds with a less pronounced effect on factor D. The ratio of factor D to factor D inhibition varies between about 2.1 and 4.1, depending on the specific LMWH product. LMWHs with a smaller mean molecular weight are predominantly excreted by the kidneys and can therefore accumulate in patients with renal insufficiency, something to watch out for. Vitamin K antagonists like warfarin, acenocumarol, and fenprocumin are administered orally. They inhibit the gamma carboxylation of specific coagulation factors, 2, 7, 9X, and X. This modification is necessary for these factors to be fully functional in the clotting cascade.
And the newer direct anticoagulants.
Right, the direct anticoagulants, unlike the heparins or fondaparinux, don't require the presence of antithrombin to exert their effect. These include direct thrombin, or factor 3 inhibitors, such as hirudin and argatropin, and the direct oral anticoagulant dabigatran, which also inhibits factor 2. The direct oral anticoagulants that inhibit factor Zas are often referred to as oral factor Zeta inhibitors, and these include apixaban, edoxaban, and rivaroxaban.
Okay, let's get into the practical aspects of dosing and administration for these agents as outlined in the guidelines. It's important stuff for daily practice. Starting with unfractionated heparin, section 2.3.3.1. UFH can be administered either as a continuous intravenous infusion or subcutaneously. Table 6 in the source provides recommended initial dosing for intravenous administration, detailing both non-body weight adjusted regimens, like a 5,000 international unit bolus followed by 1,250 to 1,280 international units per hour continuous infusion, and body weight adjusted regimens. An 80 international units per kilogram bolus followed by 18 international units per kilogram per hour infusion. For subcutaneous administration, fixed dose regimens, like 333 international units per kilogram, initially followed by 250 international units per kilogram every 12 hours, and adjusted dose regimens, a 5,000 international unit bolus followed by 17,500 international units every 12 hours, adjusted based on APTT, are mentioned. A key aspect of using UFH intravenously is the need for routine laboratory monitoring using the activated partial thromboplastin time, or APTT, to ensure therapeutic levels are achieved. Table 7 provides a nomogram for dose adjustment of the infusion based on the measured APTT, targeting a range of typically 46 to 70 seconds, corresponding to a specific ratio relative to the normal value. And a significant risk associated with UFH therapy is heparin-induced thrombocytopenia, or HIT.
Yes, always need to be mindful of HIT. Now, for low molecular weight heparins, section 2.3.3.2, administration is subcutaneous, and the dose is adjusted based on patient body weight. They can be administered either once or twice daily, depending on the specific product's summary of product characteristics, which also provides guidance on specific dose adjustments for renal function. Routine laboratory monitoring is usually not needed with LMWHs. However, target peak anti-factor Z levels, measured 4 hours after the last injection, are relevant in special situations, such as in patients with renal insufficiency, extremes of weight, or during pregnancy. The target range for twice-daily administration is typically 0.6 to 1.0 international units per milliliter. As mentioned, LMWHs are predominantly excreted by the kidney, meaning they can accumulate in patients with renal insufficiency, necessitating dose adjustments or careful monitoring. Like UFH, there is a risk of HIT, although it's less common than with UFH. The source notes that fondaparinux does not appear to cause HIT.
Okay. Vitamin K antagonists, section 2.3.3.3, administered orally. We already discussed their mechanism. When initiating VKA therapy for DVT, it's typically started concurrently with a parenteral anticoagulant, either UFH or LMWH. The parenteral agent is then discontinued only after the VKA has been administered for a minimum of 5 days. AND, a therapeutic international normalized ratio, or INR, of greater than 2.0 has been achieved and maintained for 2 consecutive days. That overlap is key.
Absolutely crucial overlap period.
Fondaparinux, section 2.3.3.4, is a synthetic pentasaccharide that inhibits factor X indirectly via antithrombin. It's administered subcutaneously once daily with the dose adjusted for body weight. Fondaparinux is predominantly excreted renally, making it contraindicated in patients with severe renal impairment, defined as a creatinine clearance of less than 30 milliliters per minute. And as noted earlier, it does not cause HIT.
Good summary. Now for the direct oral anticoagulants, the DOACs. Section 2.3.3.5 discusses dabigatran. Dabigatran is a direct thrombin, or factor TIA inhibitor. It's typically started after an initial period of 5 to 10 days of parenteral anticoagulation with either LMWH or UFH. The standard dose for treating DVT is 150 milligrams twice daily. A reduced dose of 110 milligrams twice daily is recommended for patients with specific renal function, defined as a creatinine clearance between 30 and 50 milliliters per minute. Drug interactions are important to consider, particularly with key glycoprotein inhibitors, and a specific reversal agent, adaratuzumab, is available for dabigatran.
Okay. Section 2.3.3.6 covers apixaban, a direct factor add inhibitor. Apixaban is unique among the DOACs used for DVT treatment in that it is started without an initial period of parenteral therapy. However, it requires a higher dose for the first 7 days, specifically 10 milligrams twice daily, followed by the standard treatment dose of 5 milligrams twice daily. The source notes that, in contrast to its use for atrial fibrillation, no specific dose adjustment is specified for DVT treatment in the presence of renal insufficiency. Nevertheless, caution is needed for patients with a creatinine clearance between 15 and 29 milliliters per minute, and it's not recommended at all for patients with a creatinine clearance below 15 milliliters per minute. A lower dose of 2.5 milligrams twice daily is used for extended therapy, which we'll discuss later. Reversal agents for apixaban include factor ESI inhibitors reversal agents such as andexanet alpha if it is available, or prothrombin complex concentrate, PCC. Drug interactions, particularly with strong inhibitors of CYP3A4 and P-glycoprotein, should also be considered.
And section 2.3.3.7 details rivaroxaban, another direct factor XI inhibitor. Like apixaban, rivaroxaban is started without an initial period of parenteral therapy. It requires a higher dose for the first 3 weeks, specifically 15 milligrams twice daily, followed by the standard treatment dose of 20 milligrams once daily. Similar to apixaban, the source notes that in contrast to its use for atrial fibrillation, there is no fixed dose adjustment recommended for patients with a creatinine clearance between 15 and 49 milliliters per minute. Instead, a dose of either 20 or 15 milligrams once daily can be selected in this creatinine clearance range, respectively, depending on the patient's risk of bleeding. Reversal agents for rivaroxaban include factor XI inhibitors reversal agents, such as andexanet alpha if available, or PCC. Drug interactions, particularly with strong inhibitors of CYP3A4 and of key glycoprotein, are also important to consider.
Okay, so to quickly compare some key properties, Table 8 presents a comparison between the DOACs and VKAs. Both classes are administered orally. However, only VKAs require routine coagulation monitoring, specifically the INR. The availability of specific reversal agents differs, with specific agents for dabigatran and factor Z inhibitors being available or in development, compound to vitamin K and clotting factors like PCC for VKAs. Drug interaction profiles also differ between the classes, as noted in the source.
Right. Now, Section 2.3.4 addresses the management of bleeding complications, which is, of course, a significant consideration with any anticoagulant therapy. Section 2.3.4.1 discusses bleeding risk stratification. The guidelines mention that the American College of Chest Physicians, or ACCP, consensus categorization of bleeding risk is frequently advocated. While not formally validated as a predictive score, it considers various risk factors such as older age, previous bleeding events, active cancer, renal or liver failure, thrombocytopenia, diabetes, concomitant antiplatelet treatment, poor control of the INR for patients on VKAs, other comorbidities, recent surgery, frequent falls, and alcohol abuse. A long list.
It is. But it's crucial to highlight, as the source does, that a major limitation with this categorization and other bleeding risk scores is their, well, poor positive predictive value. This means that many patients identified as being at high risk by these scores don't actually experience a bleed. Nevertheless, careful clinical assessment of individual patient risk factors for bleeding remains absolutely essential in determining the most appropriate anticoagulant and management strategy. You can't just rely on a score.
Absolutely not. Clinical judgment is key. Section 2.3.4.2 details reversal strategies for managing bleeding with different anticoagulants, drawing information from the source text and Table 10. For unfractionated heparin, Section 2.3.4.2.1, reversal is achieved using protamine sulfate.
Okay.
For low molecular weight heparins, Section 2.3.4.2.2, protamine sulfate provides partial reversal. It's not complete. For vitamin K antagonists, Section 2.3.4.2.3, reversal involves administering vitamin K, which can be given orally or intravenously depending on the urgency. For rapid reversal in cases of severe bleeding or a very high INR, clotting factors should be administered. Prothrombin complex concentrate, or PCC, is generally preferred over fresh frozen plasma, FFP, for its more rapid and concentrated delivery of vitamin K-dependent clotting factors. Table 9 provides recommendations for warfarin reversal based on the patient's INR and the severity of bleeding.
And for the DOACs?
Section 2.3.4.2.4 covers reversal strategies for DOACs. The guidelines explain that specific reversal agents exist or are under development for this class. For dabigatran, the rituximab is the specific reversal agent, and the recommended dose is described in the source. For the factor Z inhibitors, such as apixaban, rivaroxaban, and edoxaban, andexanet alpha is a specific reversal agent, if it is available. The dosing involves a bolus followed by an infusion, as described. The guidelines note that PCC can be used as a general reversal agent for factor Z inhibitors if andexanet alpha is unavailable, but it should not be administered prophylactically, meaning before blinding occurs in the case of emergency or urgent procedures. It is recommended, however, to have PCC available in case of uncontrolled bleeding.
Okay. Any other practical considerations for DOAC reversal?
Yes. Section 2.3.4.2.5 discusses practical considerations. As DOACs generally have a short half-life, as noted in Table 8, simply discontinuing the medication is often sufficient to manage the bleeding risk, particularly to facilitate elective surgical procedures, unless the patient has significant renal impairment. Table 16 provides detailed guidance on the timing of the last DOAC intake before an elective intervention based on the specific agent, the patient's creatinine clearance, and the perceived bleeding risk of the procedure. Very useful table. For managing bleeding, including life-threatening bleeding, the guidelines also emphasize supportive measures in addition to specific reversal agents. These include achieving local hemostasis, fluid replacement, red blood cell substitution if necessary, platelet substitution in case of thrombocytopenia or platelet dysfunction, FFP as a plasma expander, though not considered a primary reversal agent for DOACs, and considering adjuvant therapies like tranexamic acid or desmopressin in special cases.
Okay. Now, Section 2.3.5 addresses heparin-induced thrombocytopenia, or HIT. That's an immune-mediated complication that can occur with heparin therapy. Right.
Exactly. The initial suspicion of HIT is based on clinical features. The guidelines introduce the 4T test, detailed in Table 11, as a practical clinical scoring system for estimating the probability of HIT. The 4 Ts are thrombocytopenia, the degree of platelet count fall, timing of the platelet count fall relative to heparin exposure, thrombosis or other clinical sequelae occurring in conjunction with the thrombocytopenia, and alternative causes for the thrombocytopenia. The test provides low, intermediate, and high probability scores, and the source provides the negative and positive predictive values associated with these scores, noting the high negative predictive value of a low score. These scores are used to guide further investigation, specifically antibody testing and management.
And how is HIT managed?
The management principles for suspected or confirmed HIT are critical. The guideline emphasizes the immediate discontinuation of all heparin products, including UFH and LMWHs. Alternative anticoagulants are then used in this setting. Options include fondaparinux, which, as we said, does not appear to cause HIT, or direct thrombin inhibitors like hyaridin or argatroban. DOACs, such as dabigatran, may also be used, although their specific role and timing can be debated and require careful consideration. The management of HIT is complex and often requires consultation with a specialist.
Right. Okay, Section 2.3.6 discusses the outpatient treatment of deep vein thrombosis. This seems to be standard now.
Yes, the role of treating most patients with uncomplicated deep vein thrombosis in an outpatient setting is very well established. This approach was first supported by randomized studies way back in the 1990s and later confirmed by Cochrane reviews. The introduction of DOACs as recommended first-line treatment for DVT, due to their oral administration and predictable pharmacokinetics, has further facilitated the widespread adoption of outpatient management, which is now considered the standard of care for the majority of patients with uncomplicated DVT.
But are there situations where outpatient management might still not be appropriate?
Yes, the guidelines list conditions that typically excluded patients from the original home treatment trials and may still preclude outpatient management in current practice. These include massive or recurrent DVT, pulmonary embolism or a high risk of developing it, a contraindication to receiving anticoagulation therapy, other comorbidities requiring hospitalization, the patient living far from a healthcare facility that can provide support and monitoring, and the presence of social circumstances that may not support home treatment, such as concerns about noncompliance with medication, lack of family or social support, the patient living alone, or potential difficulty returning to the healthcare facility if complications were to develop. But despite these exclusion criteria, the reality is that outpatient management is indeed the standard of care for most patients with deep vein thrombosis today.
Okay, let's take a moment for a comprehensive mega recap covering the treatment of deep vein thrombosis with anticoagulation. We started by defining the three distinct phases of anticoagulation treatment. Initial, principal, typically 3 months, and extended. We introduced the main classes of anticoagulants, used UFH, LMWH, VKAs, fondaparinux, and DOACs, and briefly touched upon their mechanisms. We went into detail on the practical aspects of prescribing each agent: dosing, administration routes, monitoring needs, especially for UFH and VKAs, and in special situations for LMWHs, and specific considerations like renal function and HIT risk. We compared key properties of DOACs and VKAs. We then discussed the crucial aspect of managing bleeding complications, covering bleeding risk assessment and detailing specific reversal strategies for each class, including the newer agents for DOACs and the use of PCC. We covered HIT, explaining the 4T test and management principles. Finally, we addressed the established role of outpatient treatment for DVT and the circumstances where hospitalization might still be needed.
Excellent recap. Okay, let's do a quick micro recap focusing specifically on bleeding management and HIT. We highlighted that assessing bleeding risk is important clinically, even if predictive scores aren't perfect. We walked through the specific reversal strategies for each anticoagulant class, detailing how to handle bleeding with VKAs, using vitamin K and clotting factors like PCC, and the approaches for DOACs, including specific agents like idursulfimab for dabigatran and andexanet alpha for factor A inhibitors, noting PCC as a general option. We also covered the practical considerations for DOAC reversal and timing around procedures. Regarding HIT, we explained how the 4T test helps estimate clinical probability and guide further testing, and outline the immediate management steps: discontinuing heparin and using alternative anticoagulants. These are critical practical points for managing patients on these therapies.
Great. Moving specifically into the duration of anticoagulation therapy now, Section 2.3.6.2 focuses on patients who have experienced provoked deep vein thrombosis.
Yes. The guidelines cite a meta-analysis that evaluated the risk of recurrence after stopping anticoagulation for provoked DVT. The risk of recurrent VTE after provoked DVT caused by a transient risk factor was reported to be 3.3% per patient year for up to 24 months after stopping anticoagulation.
But importantly, the source highlights a significant difference in the risk of recurrent VTE based on the type of transient risk factor, right?
Exactly. The risk of recurrence was found to be much lower when the provoking factor was surgery, reported at only 0.7% per patient year, compared to patients who had a non-surgical transient provoking factor. These non-surgical transient factors include things like immobilization, hormone therapy, long-distance travel, fractures, major trauma, or pregnancy. This distinction suggests that not all transient risk factors carry the same weight in terms of future recurrence risk.
Okay. So based on this understanding, what are the specific recommendations for duration after provoked DVT?
Recommendation 16 states, for patients with provoked proximal deep vein thrombosis caused by a transient risk factor, anticoagulation therapy for 3 months is recommended. This is a strong recommendation, Class 1, based on Level A evidence establishing 3 months as the standard duration when a clear transient provoking factor is present and is no longer active.
What about persistent risk factors?
Recommendation 17 addresses patients with a persistent risk factor other than malignancy. It states, in selected patients with provoked proximal deep vein thrombosis with a persistent risk factor other than malignancy, anticoagulation beyond 3 months should be considered after evaluation of thrombotic and bleeding risks with periodic reassessment. This is a Class 2A recommendation based on Level C evidence. The rationale here is that persistent risk factors, unlike transient ones, mean there is an ongoing elevated risk of recurrence. Therefore, extending anticoagulation beyond the standard 3 months is generally recommended, but it requires careful consideration of the individual patient's balance between their ongoing thrombotic risk and the risk of bleeding, with periodic reevaluation of this balance over time.
And minor transient risk factors.
Recommendation 18 considers patients with a minor transient risk factor. It states, in selected patients with provoked proximal deep vein thrombosis with a minor transient risk factor, anticoagulation beyond 3 months may be considered. This is a Class 2B recommendation based on Level C evidence. The use of may be considered reflects the nuance that while a minor transient factor might slightly elevate the risk compared to a major transient factor, the evidence is less strong than for persistent risk factors, and the decision to extend therapy is less well established, requiring careful individual assessment. Okay. Moving to Section 2.3.7, the treatment of unprovoked deep vein thrombosis. As we touched on earlier when discussing epidemiology, the source reiterates that unprovoked VTE carries a high and continuing risk of recurrence compared with the provoked VTE. A hazard ratio of 0.55 is cited for provoked versus unprovoked VTE, indicating that provoked events have a significantly lower risk of recurrence. This higher ongoing risk is why the duration of anticoagulation is, well, a more complex decision for unprovoked events. Precisely. Section 2.3.7.1 provides recommendations on anticoagulants for the principal treatment phase of unprovoked DVT. Now, Recommendation 15 actually applies to provoked DVT not related to cancer or pregnancy, stating DOACs are preferred over LMWH-VKA, Class 1, Level A.
Ah, okay, thanks for that correction. So, Recommendation 19 is the one specifically for unprovoked proximal DVT.
Yes. Recommendation 19 states, for patients with unprovoked proximal deep vein thrombosis, treatment with a direct oral anticoagulant is recommended over treatment with low molecular weight heparin, followed by a vitamin K antagonist for the principal treatment phase. This is a strong recommendation, Class 1, based on Level A evidence reflecting the robust data supporting the efficacy and safety of DOACs compared to the traditional approach for the initial 3 months of treatment in this patient group.
Okay. Section 2.3.7.2 specifically addresses the duration of anticoagulation therapy after unprovoked DVT. Similar to provoked DVT, patients with unprovoked DVT require the same initial anticoagulation for up to 3 months. However, in view of the higher and continuing risk of recurrence associated with unprovoked events, many studies have evaluated the potential role of extended anticoagulation therapy beyond this initial 3-month period.
All right, Section 2.3.7.3 delves into extended anticoagulation after unprovoked DVT. Section 2.3.7.3.1 summarizes findings related to VKAs and aspirin for extended anticoagulation. The source discusses trials and meta-analyses comparing different durations of VKA therapy, as well as comparing VKAs and aspirin to placebo or no treatment for extended anticoagulation following unprovoked VTE. When comparing extended anticoagulation, VKAs or DOACs, to placebo or aspirin, studies consistently show a significant reduction in the risk of recurrent VTE with anticoagulation. The source quotes relative risk reductions from a meta-analysis. VKA studies showed a 91% reduction in recurrent events, DOAC studies showed an 84% reduction, while aspirin studies showed the smallest reduction at just 38%. This data strongly supports the use of potent anticoagulation over aspirin for extended therapy in high-risk patients.
And based on these findings, recommendation 24 is quite definitive, isn't it? For patients with unprovoked deep vein thrombosis, aspirin is not recommended for extended antithrombotic therapy. That's a Class 3 Level A recommendation. A strong negative based on evidence showing it's significantly less effective than full anticoagulation.
Absolutely. Don't use aspirin for this purpose. Section 2.3.7.4 discusses the role of DOACs for extended anticoagulation. The source summarizes meta-analyses comparing reduced-dose DOACs, specifically apixaban 2.5 milligrams twice daily and rivaroxaban 10 milligrams once daily, with full-dose DOACs, VKAs, or placebo aspirin in patients requiring extended therapy after unprovoked VTE. These analyses highlight that using a reduced dose of a DOAC offers a balance between providing protection against recurrent VTE and having a reduced risk of bleeding compared to full-dose anticoagulation. Furthermore, reduced-dose DOACs provide better recurrence protection than aspirin or placebo. The findings indicate that in patients where there is clinical equipoise regarding continued anticoagulation, using a reduced dose of a DOAC offers a new option that provides recurrence protection with a reduced bleeding risk.
Okay, so based on the evidence regarding the high risk of recurrence with unprovoked DVT and the effectiveness of extended therapy, recommendation 21 states, for patients with unprovoked proximal deep vein thrombosis, extended anticoagulation beyond 3 months is recommended after evaluation of thrombotic and bleeding risks with periodic reassessment. This is a strong recommendation, Class 1, Level A, indicating that for most patients with unprovoked proximal DVT, continuing anticoagulation beyond 3 months is the recommended approach.
That's the general rule now, yes.
And recommendation 22 provides guidance on the choice of anticoagulant for extended therapy after unprovoked proximal DVT, it states. For patients with unprovoked proximal deep vein thrombosis requiring extended anticoagulation beyond 3 months, treatment with direct oral anticoagulants should be considered over vitamin K antagonists. This is a Class 2A recommendation based on Level B evidence. So this recommendation reflects the growing evidence supporting DOACs for extended therapy due to comparable efficacy, potentially lower bleeding risk, and greater convenience, although the Class 2A level indicates VKOs are still a valid option and the choice should be individualized.
Correct. It's a preference, not an absolute mandate.
And recommendation 23 offers a specific strategy for certain patients on extended therapy, it states. For patients with unprovoked proximal deep vein thrombosis requiring extended anticoagulation beyond 6 months but not deemed to be at very high risk of recurrence, use of a reduced dose of the direct oral anticoagulants apixaban, 2.5 milligrams twice a day, or rivaroxaban, 10 milligrams once a day should be considered. This is also a Class 2A recommendation, Level B evidence. So this provides an option for carefully selected patients continuing extended therapy beyond 6 months, allowing for a balance between preventing recurrence and minimizing bleeding risk by using a lower dose DOAC, though importantly not for patients at very high risk of recurrence.
It's exactly. Section 2.3.7.4 discusses risk prediction models to help guide the duration of anticoagulation after unprovoked VTE. The guidelines mention the availability of various prognostic models designed to estimate a patient's individual recurrence risk. One such model is the HERD-002 model, which includes predictors such as post-thrombotic signs, D-dimer level measured while the patient is on anticoagulation, BMI of 30 or higher, or age greater than 65 years. Notably, the HERD-002 model includes estrogen-associated VTE as a component of unprovoked VTE in its assessment.
Okay, what others?
Another model mentioned is the Vienna prediction model. This model uses a Cox proportional hazards model and includes sex, the site of the index event where the clot occurred, and D-dimer levels as predictors. An individualized cumulative recurrence rate after 1 and 5 years can be estimated using an internet calculator or a nomogram. The Vienna prediction model explicitly states that it does not include estrogen-associated VTE as a component of unprovoked VTE.
On the third one.
A third model discussed is the DASH questionnaire score. This model also uses a Cox proportional hazards model and includes predictors such as abnormal D-dimer levels, age less than 50 years, male sex, and hormone use. It can be used to calculate an individualized cumulative recurrence risk at 1, 2, and 5 years. The guidelines do note that the definition of unprovoked VTE was not uniform across these 3 prediction models, particularly regarding the inclusion of pregnancy, immobility, and hormone intake. So some inconsistencies there.
Right, and how good are these models? What about their validation?
Well, an assessment of the quality of studies developing these models using the PROBAST assessment tool found some methodological concerns with the HERD-002 model, while the Vienna and DASH models were generally developed with strong methodology. However, all models were considered at least at moderate risk of bias. The primary reason for this assessment of bias is the need for further external validation, meaning confirming that the model performs accurately in different patient populations than the one in which it was developed. Only the Vienna score and the HERD-002 model had undergone some degree of external validation at the time these guidelines were published.
So useful, but maybe used with caution.
Precisely. Despite these limitations, the guidelines acknowledge the utility of these models for individualizing recurrence risk assessment and mention that they could be a valuable tool to aid in shared decision-making with patients regarding the duration of anticoagulation.
Okay. Section 2.3.7.5 addresses the bleeding risk associated with extended anticoagulation.
Yes. The guidelines discuss the increased risk of bleeding, particularly major bleeding, when comparing extended anticoagulation with VKAs to placebo or no treatment. Studies have shown that VKAs increase the risk of major bleeding with a relative risk around 2.5.
But what about the reduced dose DOACs we mentioned?
Right, as we discussed earlier, the guidelines reiterate the findings regarding reduced dose DOACs for extended therapy. Meta-analyses have shown that the rates of major or clinically relevant non-major bleeding events with reduced dose DOACs are similar to those observed with aspirin or placebo, suggesting a favorable bleeding profile for extended therapy compared to full-dose anticoagulation. Furthermore, there was a trend towards fewer bleeding events with reduced dose DOACs compared to full-dose DOACs in these analyses, a potentially safer option for long-term use.
Interesting. So how does this all come together in terms of deciding duration based on risk?
Section 2.3.7 presents a synthesis of duration recommendations in relation to the stratification of VTE recurrence risk, summarized nicely in Table 15. This table suggests different durations of anticoagulation based on whether the patient's risk of recurrence is considered high, intermediate, or low. For patients considered at high risk, such as those with active cancer, a persistent major risk factor, or severe thrombophilia like antiphospholipid syndrome, indefinite anticoagulation is recommended, provided there isn't a strong contraindication due to a high risk of bleeding.
And intermediate or low risk?
For patients at intermediate risk, the decision on duration is less straightforward. Further factors should be considered, including specific risk factors for thrombosis, the patient's individual risk of bleeding, and, importantly, patient preference. For patients at low risk, typically those whose DVT was provoked by a major transient risk factor, anticoagulation can usually be stopped after 3 or perhaps a maximum of 6 months. The guidelines note that decisions regarding extended anticoagulation are most straightforward at the extremes of this risk spectrum, meaning patients at very high or very low risk. It has also suggested that patients with provoked DVT due to minor risk factors may also benefit from extended anticoagulation, implying that a strategy similar to that for unprovoked DVT may be discussed with these patients, highlighting the evolving understanding of risk even in provoked events.
Okay. Section 2.3.8 tackles bridging therapy before and after invasive procedures. What's the concept here?
The concept of bridging therapy refers to the management of anticoagulation when patients who are receiving treatment for DVT need an invasive procedure, like surgery. This involves carefully balancing the risk of bleeding associated with the procedure against the risk of developing a thrombotic event if anticoagulation is temporarily stopped. The decision on how to manage anticoagulation around a procedure also takes into account the time that has passed since the most recent DVT event.
And what are the strategies?
The guidelines discuss different strategies depending on the procedure and the anticoagulant. For some interventions that carry a low risk of bleeding, it may be feasible to proceed with the procedure without stopping anticoagulation at all. When temporary cessation is required, the timing of the last dose before the invasive procedure depends on the specific anticoagulant being used. VKAs are considered the most unpredictable, as their long half-life means several days of remission may be needed for the INR to drop into the normal range. LMWHs typically require omission approximately 24 hours prior to the invasive procedure. For DOACs, the stopping time is usually between 24 and 72 hours before the intervention. The exact timing depends on the specific agent, the dose, the patient's renal function, creatinine clearance, and the perceived bleeding risk of the procedure itself. Table 16 provides detailed guidance on the timing of the last DOAC intake for elective interventions based on creatinine clearance and bleeding risk, a very practical table.
Okay, and is bridging with LMWH needed when stopping DOACs?
Usually not. The guidelines explicitly state that when DOACs are stopped prior to an invasive procedure, bridging therapy with LMWH is usually not needed due to the relatively short half-lives of the DOACs.
What about for patients on VKAs?
For patients on VKAs, bridging therapy with weight-adjusted doses of LMWH may be considered. This can offer a practical solution for maintaining some level of anticoagulation while the INR is subtherapeutic, potentially avoiding hospital admission for intravenous heparin. Bridging might be suggested during the initial 3-month period of DVT treatment when the thrombotic risk is highest, or for patients with cancer who also have a high risk of VTE recurrence.
But is bridging always recommended in these VKA patients?
Crucially, no. The guidelines state that bridging therapy is generally not recommended after the initial 3 months of anticoagulation therapy. This is because in most situations after 3 months, the risk of bleeding associated with bridging therapy is considered to outweigh the remaining thrombotic risk, unless specific comorbidities or patient factors indicate otherwise. This highlights a definite shift away from routine bridging in many scenarios once that acute phase of risk has passed. Okay, let's summarize our deep dive into DVT anticoagulation duration and bridging therapy with a mega recap. We covered the recommended durations of anticoagulation for provoked DVT, typically 3 months for transient risk factors, considering longer for persistent or minor transient factors. For unprovoked DVT, extended anticoagulation beyond 3 months is generally recommended for proximal events. We discussed the evidence and guidelines recommendations for the preferred use of DOAS during the principal phase and their consideration for extended therapy, including the role of reduced-dose DOACs for extended treatment in selected patients.
We highlighted why aspirin is explicitly not recommended for extended antithrombotic therapy. We explored the role of risk prediction models in helping guide duration decisions and the importance of assessing bleeding risk. Finally, we detailed the approach to bridging therapy around invasive procedures, outlining when to stop anticoagulation, the specific timing considerations for different agents, and clarifying when bridging might be considered, which is rarely, and when it's generally not recommended, particularly after the initial 3 months of treatment.
Perfect. Let's take a quick micro recap moment to really nail down the controversial role of early thrombus removal therapies, because this comes up a lot. We talked about these techniques, surgical, CDT, PCDT, being explored to potentially reduce post-thrombotic syndrome after extensive DVT. We reviewed the key trials, CAVENT, ATTRACT, and CAVIA, and their, sometimes conflicting findings regarding PTS reduction versus the associated risk of major bleeding. We highlighted the limitations of these trials, like low stenting rates and technological changes that complicate applying them today. The guidelines, based on the current evidence, specifically recommend that early thrombus removal using catheter-based techniques may be considered, that's Class 2A, for selected patients with symptomatic iliofemoral DVT, recommendation 34, emphasizing it's not for everyone, particularly those with high bleeding risk or less extensive clots. And crucially, early thrombus removal is not recommended, Class 3, for DVT isolated to the calf veins or femoropopliteal veins, recommendation 35, as studies haven't shown benefit there and the bleeding risk isn't justified. This really underscores the ongoing debate and the need for careful patient selection.
Very well summarized. Now let's move on to Section 2.4, Recurrent Deep Vein Thrombosis. The guidelines stress the importance of accurate documentation of the full extent of the initial DVT event. Ideally, this documentation should include imaging, like ultrasound, performed at the end of the initial course of anticoagulation therapy. This helps establish a new baseline anatomical status, which is likely to be useful in the future for accurately diagnosing a recurrent, meaning a second or subsequent DVT event, should the patient experience new symptoms.
Right, because diagnosing recurrence can be particularly challenging, especially differentiating between a new clot forming and just persistent residual obstruction from the original DVT. Having that baseline imaging sounds invaluable.
It really is. Regarding the management of recurrent DVT, the guidelines provide clear direction for specific scenarios. Recommendation 26 states, for patients with a second or subsequent unprovoked deep venous thrombosis, extended anticoagulation therapy beyond 3 months is recommended. This is a strong recommendation, Class 1, based on Level A evidence, reflecting the significantly higher risk of further recurrence once a patient has had more than one unprovoked event. This often translates to indefinite anticoagulation, balanced against the patient's bleeding risk, of course.
Okay. What about the challenging situation where recurrence happens while the patient is already on anticoagulation?
Yes, that's tricky. In this scenario, the strategies mentioned, although supported by a low level of evidence, include switching the type of anticoagulant being used, perhaps increasing the dose of LMWH or DOAC to a higher therapeutic dose if it was previously a lower dose, or switching to a VKA and targeting a higher INR range, say 2.5 to 3.5, instead of the standard 2.0 to 3.0.
And anything else to consider in that situation?
Yes. The source adds that in this specific scenario of recurrent DVT while on anticoagulation, investigation for underlying thrombophilia and occult cancer should be reconsidered even if it was done previously, to rule out new or missed contributing factors. Furthermore, the bleeding risk stratification should be reevaluated before implementing changes to the anticoagulation strategy, given that more intensive anticoagulation carries a higher risk of bleeding.
Makes sense. Okay, transitioning to section 2.7, post-thrombotic syndrome, or PTS.
Right. The guidelines reiterate that PTS is a common, potentially severe, and often chronic complication following DVT. Its incidence is cited as ranging from 25% to as high as 75% after expensive DVT. The guidelines emphasize its significant burden, encompassing both financial costs and a substantial reduction in patient quality of life. And as there is currently no cure for established PTS, preventing its development during the acute treatment phase of DVT is considered crucial.
We briefly touched on the pathophysiology earlier, but the guidelines describe it again here. PTS is thought to be a result of chronic venous hypertension caused by a combination of vein wall remodeling, persistent venous outflow obstruction, and venous valvular damage leading to reflux, often even after the vein has recanalized. Known risk factors for developing PTS, as listed in the source, include older age, obesity, the extent of the DVT, with extensive or proximal DVT carrying higher risk, ipsilateral recurrence of DVT in the same leg, elevated D-dimer levels, and residual venous obstruction, meaning clot that hasn't fully resolved at the end of anticoagulation.
And compression therapy, specifically using elastic compression stockings, is discussed as a potential strategy for preventing PTS.
Right. Elastic compression stockings are described, highlighting their mechanism of action, which involves reducing venous hypertension. Common types mentioned are below-knee and thigh-high stockings. They are known to provide immediate benefits for pain and edema relief. However, there are contraindications to their use, primarily severe lower extremity arterial disease, particularly with an ankle brachial index below 0.50 or an absolute ankle pressure below 60 millimeters of mercury, and severe congestive heart failure.
Exactly. And the guidelines critically review the evidence for using elastic compression stockings to prevent PTS. They discuss the conflicting results that have emerged from major randomized controlled trials. For instance, the large SOX trial showed no benefit for elastic compression stockings compared to sham stockings in preventing PTS, while smaller, older trials had shown a significant reduction. The guidelines highlight potential issues that may explain these discrepancies, such as compliance with wearing the stockings, which varied significantly across the trials. Meta-analyses, including a Cochrane review, are discussed. These meta-analyses conclude that there is significant heterogeneity between the studies, meaning the results differ substantially. But overall, the effect of elastic compression stockings for the prevention of PTS is considered more likely to favor compression, especially in patients who are compliant with wearing them. The latest meta-analysis cited shows a 38% relative risk reduction for the occurrence of PTS with the use of elastic compression stockings.
So still some debate there.
Definitely. The guidelines acknowledge the ongoing controversy and equipoise mentioned in the source, suggesting that further studies of compression stockings for preventing PTS are needed to definitively resolve the debate.
It's also reiterated that elastic compression stockings, while potentially beneficial for PTS prevention and symptom relief, do not prevent recurrent deep vein thrombosis. That's an important distinction.
Very important. Based on the evidence and clinical consensus, the guidelines provide specific recommendations regarding compression therapy. Recommendation 36 states, for patients anticoagulated for deep vein thrombosis, early compression at 30 to 40 mmHg, which is considered medium to high pressure, is recommended to reduce pain, edema, and residual venous obstruction. This is a strong recommendation, Class 1, based on Level A evidence, focusing on the immediate benefits for symptoms and early outcomes.
Okay, that's for symptoms. What about prevention?
Recommendation 37 states, for patients anticoagulated for deep vein thrombosis, below-knee compression stockings are recommended to reduce the risk of post-thrombotic syndrome. This is a Class 2A recommendation based on Level A evidence. While supported by Level A evidence, the Class 2A level reflects the ongoing debate and heterogeneity in the evidence from trials like SOX versus earlier studies, indicating it should be considered, but isn't a Class 1 recommendation.
And type of stocking.
Recommendation 40 provides guidance on the type. For patients with deep vein thrombosis, below-knee elastic compression stockings are recommended over thigh-length stockings to reduce the risk of post-thrombotic syndrome. This is also a Class 2A recommendation, Level A evidence. The rationale here is that below-knee stockings have shown similar efficacy in preventing PTS compared to thigh-length stockings, but are associated with fewer side effects and generally better patient compliance.
Makes sense. And how long should patients wear them?
Recommendation 38 addresses the duration. It states, for patients with deep vein thrombosis using compression stockings for post-thrombotic syndrome prevention, Discontinuation at 6 to 12 months should be considered if a low Viralta score is achieved. This is a Class 1 recommendation, Level A evidence. The Viralta score is a clinical tool used to assess PTS severity. A low score indicates mild or no symptoms.
And if symptoms persist?
Recommendation 39 provides guidance for patients with more persistent issues. For patients with deep vein thrombosis using compression stockings for PTS prevention, extended use beyond 6 to 12 months may be considered if a high Viralta score persists. This is a Class 2A recommendation based on Level C evidence. This reflects the clinical judgment needed for patients who continue to experience more severe or persistent symptoms despite initial compression therapy.
Regarding the duration of compression stocking use for PTS prevention, the guidelines discuss findings from several trials. One study showed no significant benefit for prolonged treatment of 24 months versus 6 months. The ideal DVT trial found individualized duration was non-inferior to standard 2 years. The Oxytavia study found no significant difference between 6 and 24 months for PTS prevention.
Right. Therefore, the duration recommendations 38 and 39, suggest aiming for a duration of 6 to 12 months as a baseline, but individualizing the continuation of therapy beyond that period based on the clinical response, assessed, for instance, using the Viralta score.
Okay, let's move on to Section 2.8, early thrombus removal strategies. This ties into preventing PTS too.
Right. Exactly. The high rate of PTS developing after extensive lower extremity DVT, cited as 25% to 75%, has inspired ongoing attempts at early thrombus removal. Research has clearly linked the development and progression of PTS to the persistence of venous thrombus and the associated venous valvular injury that stems from the inflammatory reaction to the thrombus. The goal of early thrombus removal is to clear the clot quickly, potentially preserving valve function and reducing long-term complications.
And what techniques are used?
The guidelines describe the techniques, which can involve either surgical or catheter-based approaches.
Section 2.8.1.1 discusses surgical thrombectomy. This procedure may be performed for acute iliofemoral DVT under general anesthesia. It involves making a venotomy or incision into the vein, typically the common femoral vein, to manually remove the thrombus. Sometimes a temporary arteriovenous fistula is created distal to the venotomy to increase blood flow through the vein and help keep it open. What's the evidence for this?
It's limited. The source cites a small Swedish RCT comparing venous thrombectomy in 13 patients with oral anticoagulants alone in 17 patients with iliofemoral DVT with 10-year follow-up. Patency at 10 years was significantly better in the surgical group, 83% is 41%. Additionally, a reduction in leg swelling and ulcers was observed favoring surgery. However, the source notes that despite these promising results, surgical thrombectomy is rarely performed now, often replaced by less invasive catheter-based techniques.
Okay, so catheter-based. Section 2.8.1.2 describes catheter-directed thrombolysis, or CDT.
Yes. This technique involves advancing a catheter into the thrombus under fluoroscopic guidance and locally delivering a thrombolytic agent, like RTPA. This process typically takes place over 2 to 3 days, with the catheter delivering the lendolytic drug directly into the clot to dissolve it. Its effectiveness is generally limited to acute thrombus, typically within the first 1 to 2 weeks after symptom onset, before the clot becomes organized. There are risks, particularly major bleeding, reported around 1.7% in the TTRET-D study.
And Section 2.8.1.3 describes pharmacomechanical catheter-directed thrombolysis, or PCDT. How is that different?
This is a combined approach using mechanical devices to help break up and remove the clot in addition to delivering lower doses of thrombolytics. The source highlights potential benefits like shorter treatment duration, hours versus days for CDT, and potentially lower endolytic dose and bleeding risk. However, it notes that while several novel mechanical thrombectomy devices used with or without lysis have become available recently, high-quality prospective evidence is currently lacking to definitively evaluate whether these confer any significant benefit over traditional PCDT or CDT alone. Still an evolving field.
Okay. Section 2.8.2 provides a summary of the key randomized trials that have evaluated these early thrombus removal strategies.
Yes. There have been 4 such RCTs, but the most significant ones discussed are the CAVANT, ITRACT, and CAVIAS studies. These trials have been the source of considerable controversy regarding the role of early thrombus removal, sometimes augmented by venous stenting.
Let's break them down. What did CAVANT show?
The CAVANT study compared adjunct CDT with RTPA plus standard anticoagulant treatment versus anticoagulant treatment alone. Both groups got oral anticoagulation for at least 6 months after. It enrolled patients with iliofemoral DVT. The primary outcome was PTS at 24 months, Viralta score 5 or ulcer. Cavan showed a significant reduction in PTS in the CDT group, with an absolute risk reduction of 14.4% at 24 months. Long-term follow-up showed this absolute risk reduction increased to 28% at 5 years. So the number needed to treat decreased from 7 at 24 months to 4 at 5 years. While no difference in quality of life was detected, the study wasn't powered for that. But worsening quality of life did correlate with higher Villalta scores.
Okay, and 8cc. That was a big one.
Yes. ATTRACT was a large multi-center RCT comparing PCDT or CDT plus anticoagulation versus anticoagulation alone. It enrolled patients with proximal DVT, including both iliofemoral and femoral popliteal clots. Primary outcome was PTS incidence at 24 months. ATTRACT found no significant reduction in the overall incidence of PPS at 24 months, about 52% in both groups. However, it did demonstrate a reduction in the incidence of moderate to severe PPS, 18% in the intervention group versus 24% in standard therapy, RR, so at 0.73, significant. But ATTRACT also reported a higher rate of major bleeding in the interventional group, 1.7% and 0.3%.
And the CAVIA study.
CAVIA was another multi-center RCT comparing ultrasound-accelerated thrombolysis versus standard anticoagulation alone. Unlike ATTRACT's, CAVIA specifically enrolled patients with iliofemoral DVT only, trying to address criticisms of ATTRACT. However, similar to ATTRACT's overall finding, CAVIA found no significant difference in venous occlusion rates or the incidence of PTS between the groups at 6 months.
So, mixed results and controversy. What about the limitations mentioned in the source?
Right. The guidelines discuss controversies and limitations. A significant challenge from CAVIA and ATTRACT is the relatively low rate of venous stenting performed when significant obstruction was present after thrombus removal, only 17% in CAVIA, 39% in ATTRACT. This low rate is attributed to a lack of clear consensus on stenting indications at the time and no defined surveillance protocols. The whole open vein hypothesis wasn't consistently applied. Furthermore, technological advances have occurred since these trials. One device used in ATTRACT is no longer available, the other has been superseded. These factors, low stenting, evolving tech, complicate interpreting the results and applying them to current best practice.
Okay. Despite these issues, what did the meta-analyses show?
The source presents meta-analysis findings. Figure 4, described verbally, looking at any PTS, suggests a lower incidence with early thrombus removal for iliofemoral DVT. Figure 5, for moderate to severe PTS, again suggests lower incidence with ETR for iliofemoral DVT. However, Figure 6, looking at major bleeding, indicates a higher risk with ETR compared to anticoagulation alone, regardless of DVT location. And for any proximal DVT, including FEMPOP, the reduction in PTS was less clear-cut in some analyses compared to just focusing on iliofemoral clots.
So, wrapping up early thrombus removal, what are the guideline recommendations?
Based on this current, albeit somewhat controversial evidence, recommendation 34 states: early thrombus removal, catheter-directed thrombolysis, or pharmacomechanical thrombus removal, may be considered in selected patients with symptomatic iliofemoral deep vein thrombosis. This is a Class 2A recommendation, Level A evidence. This indicates it's not for all patients, but may be a reasonable option in carefully selected individuals, those with symptomatic iliofemoral DVT at highest risk of PTS, extensive clot, low bleeding risk, and usually within that first 2-week window.
And the negative recommendation.
The recommendation 35 provides that strong negative. Early thrombus removal is not recommended for deep vein thrombosis isolated to the calf veins or femoropopliteal veins. This is a Class 3 recommendation, Level A evidence. The rationale is clear. Studies haven't shown benefit here, so the bleeding risk isn't justified.
Okay, let's take a moment for a comprehensive mega recap covering recurrent DVT, PTS, and early thrombus removal. We first discussed managing recurrent DVT, importance of documentation, indefinite anticoagulation for a second unprovoked event, and strategies if recurrence happens on treatment. Then we covered PTS pathophysiology, risk factors, focusing on compression therapy. We acknowledged the evidence debate for prevention but outlined the recommendations. For symptoms, Class 1, prevention, Class 2A, preferring below knee, Class 2A, and duration based on Villalta score, Class 1 and 2A. Finally, we reviewed early thrombus removal techniques, summarizing the controversial key trials, CAVIA, ATTRACT, GADI, on PTS and cleaving. We concluded with the guidelines. ETR may be considered only for selected iliofemoral DVT, Class 2A, and is not recommended for CAF or FEMPOP DVT, Class 3.
Excellent. Now let's take that quick micro recap, focusing on early thrombus removal, as you suggested earlier. We highlighted the key trial results. CAVIA showing benefit for iliofemoral DVT and preventing PTS, ATTRACT not showing overall PTS benefit but reducing moderate severe PTS, and CAVIA showing no difference. We also specifically mentioned the increased bleeding risk seen with these interventions. The guidelines recommendations reflect this complexity. ETR may be considered, Class 2A, for selected patients with symptomatic iliofemoral DVT, acknowledging the evidence but stressing careful patient selection due to risks. And crucially, it is not recommended, Class 3, for DVT limited to the calf or femoropopliteal veins. That encapsulates the nuanced position based on the data and risks.
Perfect. Moving on to Section 2.9, calf deep vein thrombosis, also known as distal deep vein thrombosis.
Right. Calf DVT is defined anatomically as involving the deep veins located below the knee. This can include the axial deep calf veins, peroneal or posterior tibial veins, or the calf muscle veins, gastrocnemius or soleal veins, or a combination. The natural history of isolated calf DVT is generally considered to have a lower risk of significant clinical consequences, specifically pulmonary embolism and proximal extension into the popliteal vein, or higher compared to proximal DVT. The source quotes the risks of proximal extension to be around 9% and symptomatic PE around 1.5%, typically occurring over about 3 months.
And because of this relatively lower perceived risk, coupled with concern for bleeding with anticoagulation, a more conservative approach of observation and repeat scanning was advocated in the past, right, before more trial evidence.
Exactly, that was the thinking. But the guidelines discuss the evidence from clinical trials and meta-analyses that have now compared anticoagulation therapy to no anticoagulation or placebo for calf DVT. These studies have consistently shown that anticoagulation treatment for calf DVT reduces the risk of VTE events, including proximal extension, symptomatic recurrence, and PE compared to no anticoagulation. Studies comparing VKA therapy for 3 months to no anticoagulation demonstrated a significant reduction. However, shorter durations, like 6 weeks with nadroparin in smaller trials, didn't always reach statistical significance. Importantly, major bleeding rates in the treated groups in these trials were generally low.
Okay. What about the role of DOACs in calf DVT? Have they been studied specifically?
Not really in large trials focusing exclusively on calf DVT. The guidelines point this out. However, the potential risk of major bleeding with DOACs here can be extrapolated from the larger proximal DVT trials, where the risk was around 0.5% for a 3-month course. Despite the lack of specific large trials, the ease of use associated with DOACs makes them an attractive option, and they are commonly used in practice for calf DVT.
So what are the guideline recommendations for managing symptomatic calf DVT?
Based on the available evidence, recommendation 45 states. For symptomatic calf deep vein thrombosis, anticoagulation or observation with serial ultrasound should be considered. This is a Class 2A recommendation, Level A evidence. It offers a choice, acknowledging the lower risk profile and allowing for shared decision-making based on individual risk factors and preferences.
And if anticoagulation is chosen?
Recommendation 46 states, if anticoagulation is chosen for symptomatic calf deep vein thrombosis, treatment for 3 months is recommended. This is a strong recommendation, Class 1, Level A evidence. This establishes the standard recommended duration if you decide to anticoagulate.
Any exceptions to that duration?
Recommendation 47 addresses a specific scenario. For patients with a single-vein postoperative calf deep vein thrombosis, anticoagulation for 6 weeks may be considered if anticoagulation is chosen. This is a Class 2B recommendation, Level C evidence. A specific, less common situation where a shorter duration might be contemplated based on lower evidence.
And the choice of agent. Can DOACs be used?
Recommendation 48 provides guidance. For patients with symptomatic calf deep vein thrombosis requiring anticoagulation, direct oral anticoagulants may be used. This is a Class 2B recommendation, Level C evidence. As we discussed, this reflects the extrapolation from proximal DVT data and lack of specific trials. So while they are an option and commonly used, the recommendation is less firm than for other scenarios.
Okay. Moving to Section 2.11, superficial vein thrombosis, or SVT. How is this defined?
SVT is defined as a clot forming within a superficial vein, typically in the leg, and often associated with underlying varicose veins. The clinical presentation is usually characteristic. A hard, thickened, red, and painful vein that can be felt along its course, sometimes with overlying skin discoloration. It's important to emphasize that despite SVT being distinct from DVT, patients with SVT are at risk of the clot propagating or extending into the adjacent deep venous system, or even developing a PE, particularly if the clot is extensive or near a deep vein junction.
And what are the risk factors for SVT?
Common ones are venous stasis, especially with varicose veins, and venous trauma or cannulation, like from IV lines. Other risk factors include a history of VTE, thrombophilia, malignancy, and systemic prothrombotic conditions like inflammatory diseases, ulcerative colitis, SLE, Berger's disease, or pernicious anemia. The guidelines note that SVT occurring in a vein that appears otherwise normal, not varicose, should raise suspicion for an underlying thrombophilia or malignancy.
Right. And what about the risk of progression to DVT or PE?
The guidelines discuss this risk. There are long-term thromboembolic risks associated with SVT, particularly if underlying varicose veins aren't treated, or if there are other underlying risk factors, like thrombophilia or malignancy. Recurrence of SVT is also common after treatment ends.
And what about just using anti-inflammatories for the pain?
While anti-inflammatory medications are frequently used to alleviate the pain and inflammation, the source explicitly states they have no effect on the thromboembolic risks. They don't prevent clot extension or PE.
Okay, so what's the evidence for anticoagulation in SVT?
The guidelines discuss anticoagulation, focusing on evidence regarding intensity and duration. They describe the Stenex study, an enoxaparin therapeutic or prophylactic dose for 12 days, which showed reduced recurrence extension. The POST study evaluated parnaparin, intermediate or prophylactic dose for 30 days, and found the longer intermediate dose reduced primary outcome events. A key trial is Callisto, comparing subcutaneous fondaparinux 2.5 milligrams daily for 45 days versus placebo. This was for SVT O, 5 centimeters long, and O 3 centimeters from the deep junction. Fondaparinux significantly reduced the composite outcome, death, symptomatic DVT, PE, SCT extension recurrence with low bleeding. Based on available data, the efficacy of fondaparinux and LMWH appears comparable, suggesting intermediate doses of LMWH may also be effective.
Are there scenarios where more intensive or longer anticoagulation might be considered?
The guidelines touch upon this based on risk factors: extensive recurrent thigh location near deep junction, 3 centimeter, malignancy, thrombophilia. Strategies mentioned include therapeutic intermediate dose longer or switching to prophylactic for a total of 3 months. However, the guidelines explicitly state there's a lack of strong evidence for routine use of this approach in these specific scenarios, or for short, SVT, 5 centimeters, even in high-risk patients.
What about surgery like high ligation?
That was frequently used in the past for SVT near the junction, but the guidelines note anticoagulation is now considered less expensive and possibly safer, largely replacing surgery for acute management.
Superficial venous intervention like stripping or ablation after the acute phase, for example, 3 months post-SVT, is considered rational to eliminate the source of stasis and potentially reduce recurrence, but this is explicitly stated as not evidence-based for preventing recurrence.
Okay, so what are the specific recommendations for SVT management?
Recommendation 49. For patients with symptomatic SVT, a clinical and/or ultrasound assessment is recommended to rule out concomitant DVT or PE, Class 1 Level C. Important first step.
Absolutely.
Recommendation 50. For patients with symptomatic SVT equal to or longer than 5 centimeters in length and located equal to or further than 3 centimeters away from the deep venous system junction, anticoagulation is recommended. Class 1 Level A. This defines the standard indication based on trial criteria.
Recommendation 51 specifies the agent and dose. For these patients, fondaparinux, 2.5 milligrams once a day, or a low molecular weight heparin at a prophylactic dose is recommended, Class 1 Level A. Preferred options based on trials like Callisto.
And recommendation 52 gives the duration. For these patients, anticoagulation for a duration of 6 weeks is recommended, Class 1 Level A, aligning with trial durations showing benefit.
Finally, the guidelines discuss the implications of SVT unrelated to venous stasis in a normal vein. These patients warrant investigation for underlying causes, thrombophilia, malignancy, systemic conditions, due to higher recurrence risk. Figure 11 provides a helpful flowchart summarizing SVT diagnosis and treatment. Okay, let's take a moment for a comprehensive mega recap covering CAF DVT and SVT. We discussed managing CAF DVT, the choice between observation or anticoagulation, Class 2A, the standard 3-month duration if anticoagulating, Class 1, with a possible 6-week option for specific post-hoc cases, Class 2B, and the potential use of DOACs based on extrapolated data, Class 2B. We then transitioned to SVT, defining it, outlining risk factors, highlighting progression risk. We reviewed evidence for anticoagulation, leading to specific recommendations for treatment if the SVT is 5 centimeters long and 3 centimeters from the deep junction, Class 1. The recommended treatment is fondaparinux 2.5 milligram daily or prophylactic LMWH, Class 1, for 6 weeks, Class 1. We also noted the importance of investigating SVT in normal veins for underlying causes.
Great. Moving on to Section 3, Upper Extremity Deep Vein Thrombosis, or UEDVT.
Section 3 discusses UEDVT, affecting deep veins in the arm, from forearm up to subclavian axillary veins. Common risk factors mentioned include catheter-related thrombosis from central lines, malignancy, inherited thrombophilia, and thoracic outlet syndrome, TOS, especially in young, active individuals due to subclavian vein compression.
And diagnosis, similar to the leg.
Pretty much. Ultrasound is first line. However, D-dimer's utility is limited due to frequent comorbidities elevating in any way. Venography was gold standard but rarely used now. CTB and MRV are alternatives. For suspected TOS, imaging like CT, CXR, or MRI is needed to look for compression sources, bony abnormalities like cervical ribs, or soft tissue like fibrous bands. Some limitations with MRV studies are noted.
What are the treatment objectives for UEDVT?
Main immediate goal is preventing clot propagation in PE. Other aims, preventing recurrence, rapid recovery, improving quality of life, and long-term, preventing upper extremity PTS. Initial treatment is anticoagulation.
And are the recommendations just extrapolated from lower extremity DVT studies?
Often, yes, due to limited specific UE-DVT data. However, findings suggest outcomes like PE recurrence or major bleeding during anticoagulation are similar for UE-DVT compared to LE-DVT.
Okay, so what's the recommended anticoagulation duration?
Recommendation 53 states. For patients with primary upper extremity deep vein thrombosis, anticoagulation therapy for 3 months is recommended. This is Class 1, Level C, consensus extrapolation. Standard duration for primary UE-DVT, not catheter cancer related.
What about early thrombus removal in the arm?
Generally, it's not recommended for most patients. Recommendation 54 states. In most patients with symptomatic primary upper extremity deep vein thrombosis, early thrombus removal is not recommended. Class 3, Level C. Strong negative.
But are there exceptions?
Yes, a specific scenario. Recommendation 55 states. In selected young and active patients with upper extremity deep vein thrombosis with severe symptoms, thrombolysis may be considered within the first 2 weeks. This is Class 2B, Level C. So maybe for a specific subset with severe symptoms early on, but weaker evidence.
Okay. What about surgery for thoracic outlet decompression?
Section 3.1.2.3 discusses this. It's considered for primary UE-DVT with clear evidence of venous TOS, often performed after thrombolysis, though timing is debated. Evidence from case series suggests better symptom relief and patency with first rib resection compared to no rib removal. But conflicting long-term findings exist, and evidence is mainly case series, not RCTs.
So the recommendation.
Recommendation 56 states. For patients with upper extremity deep vein thrombosis treated by early thrombus removal, first rib resection may be considered if there is clear evidence of venous thoracic outlet syndrome. This is Class 2B, Level C. Reflects the option in selected patients post-ETR with proven TOS, but weaker evidence. And importantly, stenting in the thoracic outlet is not recommended due to high fracture and thrombosis rates in this mobile area.
Okay. Section 3.2 briefly addresses deep vein thrombosis in unusual sites.
Yes, just acknowledges that VTE can occur in abdominal splanchnic veins, etc., and notes these are often associated with other underlying medical problems, suggesting investigation for causes is needed.
Got it. And Section 3.3 discusses catheter-related deep vein thrombosis, or CRT. This is common.
Very common, given widespread CDC use, tunneled, non-tunneled dialysis ports, PICCs. Vessel injury, stasis, motion, hypercoagulability all contribute. Screening finds high rates, 16 to 18%, but symptomatic events are lower, 1 to 5%. Consequences can include recurrence, PTS, PE, sepsis.
What are the risk factors for CRT?
A meta-analysis in cancer patients found insertion site matters, femoral subclavian jugular, tip location proximal to SVC higher risk, type PICC ports, previous DVT, metastatic disease, and thrombophilias, factor V Leiden, prothrombin gene mutation, all increase risk.
Can we prevent CRT?
Evidence is insufficient for routine prophylactic anticoagulation in all patients with CVCs. A review found UFH reduced symptomatic UE-DVT in cancer patients without increasing major bleeding, but uncertainty remains about locking solution.
In treatment.
Practice varies, anticoagulation plus anticatheter removal replacement, no RCTs on duration. A systematic review showed PE in 2.8%, recurrent 7%, major hemorrhage 2.8% on anticoagulation, often UFH-VKA, with median follow-up 1 to 5 years. One study suggested potential benefit for DOACs over standard anticoagulants, but data is limited. Okay, let's do a mega recap for upper extremity DVT, unusual sites, and CRT. We covered UE-DVT diagnosis, U.S. first-line management, standard 3-month anticoagulation Rec 53. We discussed when ETR might be considered, rarely severe symptoms, young active Rec 55 versus not recommended, most cases Rec 54. And the role of surgery for TOS, rib resection considered post-ETR if approved in TOS Rec 56. We briefly mentioned unusual sites. We then discussed CRT, its risk factors, limited prevention evidence, varied treatment strategies, and the currently limited role for DOACs. This leads nicely into the pediatric context for Recommendation 59, as CRT is common in kids.
Perfect. Moving now to Section 4, deep vein thrombosis in special populations, starting with 4.1, deep vein thrombosis in children.
Right. VTE does occur in kids, less common than adults, but often catheter-related, especially CVCs in hospitalized or ill children.
Any key trials in this population?
Yes, the guidelines mention the Einstein Jr. trial. It compared body weight adjusted rivaroxaban with standard anticoagulants, LMWH VKA, for acute VTE in children. It found safety and efficacy were comparable, a big step forward for pediatric options.
What about thrombolysis in children?
Evidence is scarce, generally reserved for limb or life-threatening situations. Given the complexities and limited evidence, practice is often guided by indirect appraisal and expert opinion. The specific bleeding and thrombosis risks need careful assessment for each child.
Which leads to a critical recommendation.
Exactly. Recommendation 59 states, the management of children with deep vein thrombosis should be guided by clinicians with specific expertise in pediatric thrombosis and hemostasis. This is Class 1, Level C, consensus. Rationale is clear. Complexity requires specialized knowledge.
Okay. Section 4.2 focuses on deep vein thrombosis in pregnancy, a high-risk state, right?
Absolutely. The guidelines strongly emphasize the significantly increased VTE risk during pregnancy and postpartum. It's a leading cause of direct maternal death in the UK. Factors like obesity and rising maternal age contribute. Physiologically, pregnancy is hypercoagulable, increased factor VIII, fibrinogen, reduced protein S, APC resistance, plus venous stasis, especially left ligiliofemoral region.
How is diagnosis handled? It must be challenging.
It is. Recommendation 60 explicitly states, in pregnant women with suspected deep vein thrombosis, the use of D-dimer and Wells score is not recommended. Class 3, Level B. D-dimer physiologically increases, making cutoffs unreliable.
So ultrasound is still first line?
Yes. But imaging for suspected iliac vein thrombosis might need MRV or conventional venography. There are concerns about potential fetal risks with these acoustic noise, heating from MRI.
What about thrombophilia testing during pregnancy?
Generally not routinely recommended except possibly for antiphospholipid antibody testing and maybe antithrombin levels if a strong family history exists. Identifying APS is important for fetal monitoring needs.
And treatment?
Anticoagulant therapy should be started promptly. The key recommendation is Recommendation 61. In pregnant women with deep vein thrombosis, therapeutic doses of low molecular weight heparin are recommended during pregnancy for at least 3 months and for at least 6 weeks postpartum. Class 1, Level B. LMWH is a standard of care.
What about other anticoagulants?
Recommendation 62 provides a strong negative. In pregnant women with deep vein thrombosis, vitamin K antagonists and direct oral anticoagulants should be avoided during pregnancy. Class 3, Level C for both. VKAs cross the placenta, causing embryopathy fetal loss. DOACs lack sufficient safety data.
Okay. And management around delivery?
Planned induction C-section helps manage risk on therapeutic anticoagulation by timing LMWH dose reduction omission. Regional anesthesia requires waiting 24 hours after the last therapeutic LMWH dose. Postpartum anticoagulation, LMWH, VKA, or DOAC are options then. Continues for the remaining duration, ensuring at least 6 weeks postpartum coverage.
Got it. Section 4.3 covers cancer-associated venous thrombosis, or CAVT.
Yes. High incidence, high recurrence risk, around 20% at 1 year, and increased bleeding risk compared to non-cancer patients. Risk influenced by cancer type stage, patient factors, treatment, biomarkers.
What's the evidence for treatment?
Guidelines discuss meta-analyses and key RCTs like OCSI VT cancer, Select-8AD, ADAM-VE, comparing LMWH and DOACs, edoxaban, rivaroxaban, and apixaban. Overall efficacy for preventing recurrent VTE was generally comparable.
But bleeding risk differed.
Yes, findings were more nuanced there. Some trials showed higher major bleeding with DOACs. For example, edoxaban and HOCSI, particularly GI cancers, rivaroxaban non-major and Select-8. ADAM-VE with apixaban showed numerically less major bleeding than dalteparin, but had limitations.
So the recommendations for CAVT?
Recommendation 63. For patients with cancer-associated deep vein thrombosis, a low molecular weight heparin is recommended for initial and principal phase anticoagulation, Class 1, Level A. LMWH remains the standard initial approach.
And for extended treatment?
Recommendation 64. For patients with active cancer-associated deep vein thrombosis, switching from a low molecular weight heparin to an oral anticoagulant is recommended after 3 to 6 months of treatment for extended treatment, Class 1, Level C. This addresses long-term LMWH challenges. While historically VKA, DOACs are increasingly used now, though the Class C reflects consensus preceding the latest DOAC data saturation.
Any other practical points for CAVT?
LMWH, fondaparinux, rivaroxaban, apixaban, or UFH are acceptable for initial phase. LMWH, fondaparinux, DOACs, rivaroxaban, apixaban, edoxaban, UFH, or VKAs for principal phase. Duration is generally as long as cancer is active. Importantly, reduced-dose DOACs are not currently recommended for extended treatment in active cancer, pending trials. Bleeding management is complex and consider mechanical compression from tumors.
Okay. Section 4.4 covers deep vein thrombosis in patients with thrombophilia. We discussed testing earlier. What about management?
Right. Testing covered in 2.2.5. General principle. Thrombophilia is one factor. Holistic risk assessment is needed. Anticoagulants are generally equally effective regardless of thrombophilia type.
What about recurrence risk after stopping anticoagulation?
It's higher with thrombophilia, but varies by type. Higher in severe hereditary types, AT deficiency, combined homozygous FVLPT, combined hetero, and APS. Severe defects often present earlier, unusual sites, recurrence, family history.
And DOAC use in thrombophilia. Still controversial.
Somewhat. Due to limited specific RCT data, VKA remains the standard for APS VTE, INR23. Some studies suggest DOACs might be an option for some, especially lower risk, but caution is needed. Unclear for high-risk APS or uncommon thrombophilias.
So key recommendations for thrombophilia patients.
Recommendation 65. For patients with DVT and high-risk thrombophilia, vitamin K antagonists are preferred for extended secondary prevention. Class 1, Level C. Reflects past practice strong VKA evidence in groups like APS.
Recommendation 66. For patients with DVT and high-risk thrombophilia, full-dose extended anticoagulant therapy is recommended with periodic reevaluation. Class 1, Level C. Examples: APS, homozygous FEL, deficiencies of PCSE. Emphasizes long-term, full intensity for severe forms. Recommendation 67 is a crucial negative one. For patients with DVT and antiphospholipid syndrome who are triple positive or have a history of arterial or small vessel thrombosis, direct oral anticoagulants should not be used. Class 3, Level B. Based on studies showing higher failure rates with DOACs versus VKAs in these specific high-risk APS subsets.
Very important one.
Recommendation 68 reinforces the standard for these high-risk APS patients. For patients with DVT and triple-positive APS, treatment with a vitamin K antagonist titrated to maintain a target INR between 2 and 3 should be considered. Class 2A, Level B. Reinforces VKA as standard here.
And finally, Recommendation 69 emphasizes expertise. The management of patients with DVT and a high-risk thrombophilia should be guided by clinicians with specific expertise in thrombophilia and hemostasis, Class 1, Level C. Complexity requires specialist input.
Okay. Section 4.5 briefly discusses deep vein thrombosis in patients with inferior vena cava anomalies.
Yes, notes the association between IVC anomalies, hypoplasia absence, and iliofemoral DVT, often in younger patients. Controversy exists on whether anomalies predispose to DVT or recurrence, potential implications for ETR stenting, complexity, and anticoagulation duration, but evidence is limited to case report series.
Section 4.6 addresses deep vein thrombosis in patients with renal impairment, CKD.
Right. CKD increases risk of both recurrent VTE and bleeding on anticoagulation. Management challenges. LMWHs, fondaparinux, DOACs, generally not recommended for end-stage renal disease, CRCL15L01. Traditional management is IV UFH followed by VKA. For moderate severe CKD, CRCL15 to 59 milliliter, LMWHs, fondaparinux require caution, dose adjustment, maybe anti-HESA monitoring. DOACs can be effective safe versus VKAs in mild moderate CKD, CRCL 3080 milliliter, but need careful consideration.
So the recommendations reflect this caution.
Yes. Recommendation 70. For patients with DVT and CKD requiring anticoagulation, monitoring of anticoagulation levels and dose reduction should be considered as most are renally excreted, Class 2A, Level C, due to bioaccumulation bleeding risk. And Recommendation 71. For patients with DVT and CKD treated with LMWH, fondaparinux, or DOAC, periodic reassessment of renal function is recommended, Class 1, Level C, crucial for safety as function can change.
Okay. Lastly, Section 4.7 addresses deep vein thrombosis in patients with extremes of body weight.
Yes, challenges at both ends. Increased bleeding risk with VKAs noted in low-weight patients, 50 to 60 kilograms.
And obesity, BMI over 30.
Specific considerations. Recommendation 73. For obese patients with DVT, fixed-dose LMWH is not recommended, Class 1, Level C, may be subtherapeutic, so Recommendation 74. For obese patients with DVT, weight-adjusted LMWH is preferred, Class 2A, Level C. Anti-IGZ monitoring may be considered, especially at very high weights.
What about DOACs and obesity?
Studies suggest rivaroxaban and begatrine can be effective safe versus warfarin, consistent across BMI classes, including very high BMI. Specific rivaroxaban dosing considerations mentioned for PE and high weight, though recommendation here is for DVT.
So the overall recommendation for extremes of weight.
Recommendation 72. For patients with DVT at extremes of body weight, dosing of LMWH, UFH, or DOCs adjusted by body weight is recommended. Class 1 Level C. Fundamental principle for achieving therapeutic levels safely.
Okay, let's do a comprehensive mega recap covering DVT in special populations. We discussed children, specialist input needed Rec 59. Pregnancy, high-risk LMWH, standard Rec 61, avoid VK wave Rec 62, diagnostic challenges Rec 60, CAVT, high-recurrence bleed, LMWH, initial Rec 63, switch oral extended Rec 64, no reduced-dose DOAC, active cancer. Thrombophilia, testing when indicated, VKA preferred high-risk APS Rec 65, full-dose extended high-risk Rec 66, avoid DOACs, triple post-arterial APS Rec 67, specialist input Rec 69, IVC anomalies briefly. Renal impairment, agent choice by CRCL, monitor just crucial Rec 70-71. Extremes of body weight, weight-based dosing key Rec 72. LMWH caveats obesity Rec 73-74.
Very thorough. Now, Section 6 in the guidelines lists recommendations for future research. The committee explicitly highlights that significant knowledge gaps remain, despite these comprehensive guidelines. They identify specific areas needing further research to improve clinical practice.
What kind of areas?
Things like etiology, racial disparities, causes of unprovoked BVT, workup, validating algorithms, CUS versus WLUS cost-effectiveness, imaging acute versus persistent thrombus, treatment, LMWH role provoked DVT, optimal DOAC role air duration, optimal duration provoked unprovoked, PTS, ECS versus sham, optimal duration, ETR, specific populations, device comparisons, combined strategies, cost-effectiveness, SVT, intermediate LMWH dose, GSV importance, specific populations, UEDVT, thrombolysis, or resection. Lots still to learn.
Right. Framing these points, these are indeed exciting areas. They represent the frontiers where future studies will continue to refine our understanding and potentially lead to even better patient outcomes and more precise guidance. Section 7 of the guidelines is titled Information for Patients. This section provides plain English summaries covering the condition, causes, symptoms, diagnosis, treatment goals, management like anticoagulation, compression, etc. Its inclusion shows the commitment to informing patients as well as clinicians, though our deep dive today focused on the detailed clinical guidance for you.
A valuable addition for patient engagement.
Well, we've reached the end of our deep dive into the European Society for Vascular Surgery 2021 Clinical Practice Guidelines on the Management of Venous Thrombosis. We've journeyed through the methodology, delved extensively into diagnosis and treatment of lower extremity DVT, explored other types, and navigated complexities in special populations. These guidelines are clearly a valuable resource for U.S. specialist clinicians.
Indeed. And maybe a final thought to leave you with. Considering the ongoing debate around optimal duration of anticoagulation for certain groups, particularly with new DOAC strategies, and the evolving landscape with technologies like reduced-dose DOACs or mechanical thrombus removal devices, the challenge for you is not just applying current guidelines, but staying abreast of the emerging evidence that will shape future practice. This will undoubtedly lead to even more personalized patient care decisions in the years to come.
A great point. Thank you for joining us on this deep dive into the ESVS guidelines.
We encourage you to continue engaging with the literature and applying critical thinking to the knowledge gained from this deep dive in your clinical practice. Type continue for further detail.